what standard are we training you to? National standard. Okay, so if you are in Kansas, let's say, right, you might be able to intubate patients depending on their protocol. Okay, but do you think you can do that here in LA?
No.
Absolutely not. Okay, they'll barely let you touch the equipment just to give it to them, and that's about it. Okay, but again, other places you may be responsible for the entire intubation procedure. All right. We're also going to go over EKGs. Is it our job to read the squiggly lines?
No.
No, but it's our job to put the stickers on the patient so the medic can go read the squiggly lines. That wasn't a question. Okay. Now, as far as IVs, okay, can we stab people?
No. Twice.
Sometimes. Okay. Only when it comes to EpiPen auto-injection or intramuscular Narcan. Not for IVs. Okay. However, again, a medic may ask us to set them up a line, and they just call it stripping a line, right? Where then they are going to go ahead and actually stab the patient and administer the medication. Okay, and that's something we do all the time here. Like, hey, stream out a line, that way they're getting their IV stuff set up, and we have it ready to go. So once they stab the patient and have the catheter in, all they have to do is plug it in, and that's it. Okay, so that's the stuff we're going to be going over. Now, with you guys just doing IFTs for right now, like, probably not going to be assisting with this stuff, but hopefully, right, when we start getting 911 again for ride-alongs, okay, people will be able to do this stuff, right? Well, you'll be running calls, and a medic says, hey, student, stream out a line, please. Okay, so if you guys are out there, right, working, hopefully you remember how to do this, so actually pay attention. That we're not sitting there fully, certified and stuff, be like, I don't know how to do that, right? Because that's not going to look good. So we're going to go over this kind of stuff. So just some boring stuff before we get to the show and tell. Obviously, okay, in EMS we are part of a team. Okay, there's us as BLS, who in the field is going to be working with ALS, right? And then with ALS treatments and stuff, we get them to the hospital, they're going to be working with nurses who then work with doctors. And then doctors work with other specialists and other doctors and so on and so forth. Okay, so we are part of a continuum of care, right, where we're going to be kind of the foundation of everything that goes on, right, for the rest of that patient's treatment plan. All right, and that's what we've been kind of emphasizing. That, yeah, even though we're the lowest rung on the ladder, okay, we are still the most important people there because everything that we do is going to be the foundation for everything they do. Okay. Now, as far as community paramedicine, again, talked about that way back in intro. Okay, they're using this stuff now to reduce the basically stress on EMS as a whole. Okay, especially the hospital. Okay, where patients have to go there for BS reasons, not BLS, but BS reasons. Okay. Where again, we're going to be sitting there holding the wall for hours and hours and hours and hours and hours on end, okay, which again is not going to be a useful way of utilizing us, okay. So with community paramedicine, they're going to be going to the patient, okay, providing care that doesn't necessarily have to require hospital treatment. So just for shits and giggles, earlier today I was trying to see what LA County has, and they actually have a little nifty little YouTube video, maybe I'll pull it up later if you got time, that kind of talks about it and how they're going to be using it here in LA, all right, just kind of going over that kind of stuff. Now, as far as our teams, just again, some more BS crap we got to cover. There are regular teams and temporary teams. Regular teams are just two partners who work together on a consistent basis. Temporary teams are two people who don't work together on a consistent basis. That's it. That's all it is. All right. So we have special teams, okay, which are teams that have, or people rather, that have other specialized training on top of just being an EMT. All right. So for example, hazmat, they may have some basic life support treatment, but they're obviously specialized in what?
Hazmat.
In hazmat cleanup. Okay, tactical EMS, right? They're going to be certified as EMTs, possibly even paramedics, but they're also going to be on the SWAT team. Okay, we have special event EMS. Easy for us because we just have to be able to manage a bunch of people with limited resources. Okay, and then you have your EMS bike team, which just means you had a good childhood and you know how to ride a bike and you passed the class. That's it. Okay, so hopefully some of you will be able to apply to that. So as far as groups. Okay, we have to be able to identify ourselves as a group by having these 5 BS things that, again, we just have to talk about. So we need to have a common goal. Our common goal is treatment of the patient, right, and providing the best care we possibly can. Okay, that is our goal, right, as an EMT and as a whole team. We have to identify ourselves as a group, whatever that means. We need to have a sense of continuity within the group, right, which means we know our different roles and responsibilities. So as an EMT, I know what I have to do, whereas the paramedic knows what they have to do, right? And we try to work with the most efficiency possible, right, to maximize our resources, right, and the treatment of the patient. A set of shared values, which means we're just doing the best we can for the patient, right, along with our different roles within the group as well. Okay. So with dependent versus independent groups, a dependent group relies upon a team leader, whereas an independent group does not require a team leader. Right? Now, it just depends on what system and what crew you work with as to how you're going to be running your calls. Okay, so for example, in LA, right, depending on who you're with, and it's individual to each crew that you're working with, they may operate dependent or independent. So for example, a dependent group is going to have a fire captain, right, or a medic who's going to be delegating roles. Hey, I want you to do vitals. I want you to get medicines. I want you to run a sample. I want you to do this. I want you to do that. That's a dependent group. Okay, where there's one person barking out all these different orders and delegating different roles and responsibilities. Whereas an independent group, okay, usually work with people, we know our strengths and weaknesses, and we play to that. So we run 50 chest pain calls, right, as a team. So I know that he's going to be the fastest one getting vitals. I know that she's pretty good at getting sample history and getting other information from the patient. I know they're good at setting up my equipment for me. All right, guys, let's go to work, right? We just go right to it without having to be delegated our different roles and responsibilities. That's all that is as well. All right, when it comes to transfer of care, we want to try to have it as uninterrupted as possible, to the point where, again, our care is not interrupted whatsoever. So, great example of that is if you're bringing in cardiac arrest. Okay, do we stop doing CPR once we roll into the hospital? No, we keep doing it all the way through, right? Doing compressions, ventilations, and I'll be talking to the ER staff as well as we're actually pumping compressions. Hey, we got this, blah, 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 blah. All right, cool, the bed's ready to go. Okay, we've got 3 more compressions left. All right, partner's gonna ventilate as we transfer the patient to the bed, and then we pick right back up without stopping compressions, right? So again, we have to try to make our care like that as much as possible, right? As well as communicate, okay, using proper terminology, okay, and using your efficiency of words, okay? Your impressions and whatnot, okay, what you've seen, what you've done, anything else we want to do should be short and sweet, okay? They shouldn't be these 5-minute rambles, right, about irrelevant stuff. It's, I got this, here's what we've done, here's what they've said, and that's it.
Is that where you see, like, in, like, shows and stuff where, like, they're sitting on top of them on the gurney, like, compressing as, like, they wheel them in?
Sometimes, all right? So, Sean, who you guys met the other day, right? He does that all the time at the hospital because he's small enough where he can just hop on the gurney and just go. Right? He likes that stuff. So we also want to make sure that we have respectful interaction, okay, amongst everybody else, right? So even though you may have personal grudges with different hospital staff, right? You don't remember Sean? No.
Does he do with the tattoos? Like,
Clearly you weren't here on Friday, sir. Mentally, at least.
Oh,
Yeah. The other person that was there besides me, sir. There's one other person here. Okay, so again, we want to make sure you have that respectful interaction. Okay, so set aside personal grudges with people you don't like, right? Just do your job and that's it. Okay. Now, like I was saying earlier, okay, what may be a ALS skill in one place could be a BLS skill in another place. Okay, it all depends on protocol, right? Now, again, here in LA County, we're just restricted. Everybody is BLS, ALS. Okay, but if you were to go to other counties, like let's say you go to San Bernardino County, right, EMTs there have a slightly more expanded scope. Medics have a much more expanded scope compared to those that are here. Okay, so even within the state, different LEMSAs, right, will have different scopes of practice. And obviously more rural areas where we have longer transport times are going to have more expanded scopes of practice. Okay, because here in LA County, again, there's a hospital on every other street corner. So they're like, yeah, just pick them up, throw them on the gurney, bring them to us, and we'll do everything else. Okay, but in Central California, for example, right, still within California, we can have a 2-hour transport time, right, from wherever we are to a specialty center. So they're going to have more expanded scopes where EMTs might be able to innovate, right, in certain places here. I don't know every single county in their scope, but again, it's more rural areas where we can have more fun. So when it comes to airway stuff, of course, we have the upper airway, which is designed to do what with the air? Warm, humidify, and filter, right, the air as we inhale. Okay, whereas the lower airway is just a series of tubes to get it down to the alveoli, where what's going to happen? Diffusion, but what specific type of diffusion? Respiration. Okay, we have the exchange of O2 and CO2. All right. Now, we already know our BLS airway adjuncts, OPAs and NPAs. Those are all going in the upper airway. And anything that goes in the upper airway has to be clean. Has to be what?
Clean.
Has to be what?
Clean.
Whereas anything going in the lower airway has to be sterile. Okay, so anything going down to the lower airway must remain sterile, which means that we have to use aseptic technique. Kind of technique?
Aseptic.
Right, which means that we have to wear sterile gloves, right, and try not to touch anything that's not sterile. Right, not to be confused with childbirth, where, again, as we're setting up, it has to at least be medically clean, where the equipment's sterile, but we're using non-sterile BSI to handle it at the beginning. Okay, so when we go over intubation and whatnot, anything going down here has to be sterile.
Sterile.
And as far as suctioning, because we are suctioning the lower airway, everything has to be
Sterile. Sterile.
So we have to use what kind of technique? Aseptic. All right. So we'll be going over that stuff in just a bit. So when it comes to basic airway adjuncts, of course, those are the skills that we can do as EMTs. Right? And in most places, okay, they always go from small guns to big guns, least invasive to most invasive. Right? A lot of places are totally fine with just a properly functioning basic airway. Okay, so a lot of places, if the OPA is in there, it's measured correctly, doing its job, leave it alone. All right? No need to fix it if it ain't broke. Okay, now LA County is finally getting with that memo after years of doing it wrong. Okay, where I've been on cardiac arrest, we got a good OPA, medic comes in, good OPA, throws it over the shoulder and then puts a tube down the wrong place and then kills the patient. Right? So ALS is finally saying, hey, you know what? You guys are screwing up your intubations. Going to give you one chance to do it, but if there's a good OPA, leave it alone. Right? Don't even bother intubation. So they're kind of taking that away now from ALS. Right? They're really basically neutering that type of certification licensure by not allowing us to do a lot here. So just keep that in mind. And we always try to go basic before advanced. Okay? Start with the easy stuff. If it works, cool. If it doesn't, then we escalate as we keep going on. Okay? Now, as far as gastric tubes, okay, these are tubes that are going to go where?
The stomach.
Into the stomach. Okay? Now, depending on which way it goes in, will determine what we call it. If it goes up the nose, we call it a nasogastric tube. Or if it goes down the mouth, we call it an orogastric tube. Okay? But the end result is to get it into the stomach. So, here we have one of our gastric tubes. Okay, so it's a long tube, right, that's going to go into the patient. Now, the whole purpose of inserting a gastric tube is to alleviate gastric distension. Alleviate what?
Gastric distension.
And what is gastric distension?
Air in the stomach.
Air in the stomach. What is it?
Air in the stomach.
What is it?
Air in the stomach.
And if there's too much air in the stomach, what happens?
Vomit.
All right, patient's going to puke. Okay, so we want to use the gastric tube to try to suck out that extra air before his stomach gets too big, and then blah, patient throws up and makes a mess. Right? Because not only does it make a mess, but we now have the risk of aspiration, where that vomit goes into their what?
Airways.
Into their lungs. All right, so we want to go and try to insert this. Now, as far as nasogastric tubes, okay, those are going to be contraindicated, so we do not use them in patients with any suspected head, facial, or spinal trauma. Okay, so we do not use any nasogastric tubes for any suspected head, facial, or spinal trauma. Which, as we discussed when we talked about NPAs, used to be contraindications for NPAs as well way back when. But now, we just don't use NPAs in what kind of patient?
Unconscious patient.
Mm-hmm.
Oh.
Mm-hmm. I can use an NPA on a responsive patient.
Who's gag reflex? Or
Nope.
wait, no, naso.
Yeah, NPA. Who can I not use it on?
Infants.
Infants.
Oh,
We
yeah.
talked about it last night. Who can we use it on?
Infants.
Infants. Right? That's it. The only contraindication for NPAs would be an infant patient. All right? Now, the reason why the NPA used to be contraindicated in these patients is because of what they thought would happen here, which can most definitely happen with a nasogastric tube. Okay? So, this is an x-ray of somebody's head. This is a gastric tube inside their head. So now it's more of a cerebral tube, right, than anything else. Okay? So if a patient were to have any type of suspected basilar skull fracture, okay, they pass that nasogastric tube up, it can go through that fracture and start twirling inside the patient's brain and basically lobotomize them. Right? And as we talk about what to do to confirm that we're actually in the right spot, we have to aspirate contents, which means we have to suck things up. So when they started confirming placement of this, they started sucking up pink bubblegum, but it wasn't pink bubblegum. Okay? Exactly.
Hey.
All right? So we're not going to be using nasogastric tubes for those who have any suspected head, facial, or spinal trauma. Right? We've got to be really careful about ventilation so we don't cause gastric distension. Now, we will be using, or at least seeing, placement of gastric tubes in a lot of cardiac arrest patients. Okay, because as we ventilate with the BMV, right, no matter how well of a seal and stuff like that, unless there's a tube that goes directly down the trachea, you will start to get a little bit of gastric distension. Okay, that's why we don't squeeze the bag as much as we possibly can. We squeeze until we see what?
Chest
Rise and fall. Okay, that way don't put all that extra air to their stomach and then cause the patient to start puking. Hence why we have the pop-off valve in pediatric BMVs. Okay, to reduce that risk in kids, because since they got smaller stomachs, it doesn't take a lot of air to actually inflate it and cause gastric distension. So, another way of confirming placement is through an X-ray. Okay, so obviously we don't have that capability in the field, but when we get it to the hospital, they'll roll them in, check to see if it's there. All right. As far as equipment we're going to need, we obviously need the right size gastric tube. Okay, and there's different lengths, so we just go and measure it out. We're not going to talk about measurement because we don't really use it here. All right, we want to measure it out, make sure it's the correct length. We're going to need suction equipment, just in case they do still have a gag reflex, or if they do end up vomiting, we can at least suction out the airway. We want to have some tape to secure the gastric tube. Just tape it to the side of the patient's head. We'll need an emesis container in case they throw up, so at least we can catch the stuff. And we suction whatever's left in the airway. All right, we're going to need a larger syringe. We're going to need lubricant, a stethoscope. All right, so when we auscultate, okay, we actually want to auscultate gastric sounds to ensure that there's actually the tube there. We're going to blow air into it, so it's going to start to bubble. All right, so we're going to aspirate stomach contents. All right, so what we would do is we would insert this, and this mannequin doesn't take the gastric tube, otherwise I'd insert it. But we pretty much pass it down, goes into the patient's stomach, and we'll take a large syringe, something like this, and we'll go ahead and push in a little bit of air. So we'll just go ahead and say 50 cc's of air. We'll take this, we'll push as I auscultate the stomach. So I'll hear, right, and then I'm going to start sucking back until I start sucking up stomach contents. So again, in that picture of it all up in the brain, right, they started sucking up brain matter, okay, to confirm that it was in the wrong place in this case, right, to see what's going on. And then from there, we know that the stomach's full of out of air, so we don't have to worry about that. And we'll just keep on aspirating if we start to see a little bit of distension. All right. Now, one way we can tell the patient is starting to get gastric distension is they start to have left upper quadrant bulging, right, since the stomach is located where? Left upper quadrant. Okay. So we'll see it start to kind of fill up a little bit, like, oh, that's not good. All right. Then we go and aspirate contents to try to reduce that distension. All right, so we'll auscultate as they're doing that, suck up stomach contents, and then they'll get an x-ray once they get to the hospital itself. Now, another technique we can use to reduce gastric distension in the first place is what's called the Self maneuver or cricoid pressure. Okay, so now we're going all the way back to human body, right, and why the cricoid pressure is significant to know. So, Axel, what makes the cricoid cartilage special?
Full ring.
Right, it's the full ring of cartilage. Okay, now we need to use that full ring of cartilage to compress the patient's esophagus. Compress what tube?
Esophagus.
Compress what tube?
Esophagus.
Right, to compress their esophagus, not their trachea, because the trachea connects to the lungs, and we need air to go into the lungs. Okay, so I use the cricoid cartilage as it's a full ring, and I squash that esophagus. That way, air can't go down to the stomach and cause gastric distension. Okay, I also use that cricoid pressure to pinch the esophagus to reduce the amount of stuff that'll be coming back up. Okay, so I pinch down the cricoid cartilage, right, to compress the esophagus so air can't go down and stuff can't come back up. Now, as far as palpation of the cricoid cartilage, we're going to find the thyroid cartilage, right, big old Adam's apple. We're going to go right below that, find that smiley face gap. And what do you call that gap?
The xiphoid?
Nope.
No. The cricoid thyroid?
Right, the cricothyroid membrane. What is it?
Cricoid thyroid.
Right, cricothyroid membrane. And then right below that is where we have the cricoid cartilage. Okay, what you do is you take two fingers and you essentially force choke the patient, okay, as you press back on the cricoid cartilage to compress their esophagus. All right, so we're going to do something like that as we're ventilating the patient. All right, it is a bit of an older school technique, so it's not really utilized all that much anymore. But again, you may have some old school medics out there who say, hey, give me some cric pressure, right, to go ahead and push down on that. All right, now if I were to collapse their trachea, is that good?
No.
No, because you just crushed the airway. And of course, airway is
King.
Okay, and if you're not palpating the right spot, can you collapse their trachea?
Yes.
Yes, that's why you need to palpate and find the actual correct spot, right, using that cricoid pressure and compress down. So, when it comes to endotracheal intubation, okay, endo just means inside, so endotracheal is going inside the trachea. And just like with the gastric tube, depending on which way we go into the trachea will also determine its name. So we have orotracheal intubation, which is the most common, where it goes through the patient's mouth. But there's also nasotracheal intubation, where it goes through their nose. Okay, but the end result is to get it into the patient's trachea, so we have a nice secure airway going from the BMV down to their lungs. All right, now the indication for endotracheal intubation is the exact same as an OPA, to create or maintain a patent airway in an unconscious patient with no
Gag reflex.
and the contraindications if they have a
Gag reflex.
gag reflex. Okay, so the indication for an ET tube is the exact same. I want to create or maintain a patent airway in an unconscious patient with no gag reflex, but I can't use it on somebody if they have a gag reflex. All right, now again, as far as differentiating between the two, we always go with the least invasive to the most invasive. So if the OPA is in and it's working, leave it alone. Okay, but if it's not doing the job, right, then we want to go ahead and attempt endotracheal intubation. All right, so depending on our scope of practice, we might be able to intubate depending on where we are. Okay, but again, here in LA County and most of Southern California, not going to be an option for us. All right, now when it comes to usage of any type of advanced airway, we have a little phrase that we use to know these steps. That phrase is be magic. Okay, so we go and use be magic. But if we get successful intubation the first time, it's just BMAC. We get rid of the GI. So B is to perform BMV pre-oxygenation. Okay, so B is to perform BMV pre-oxygenation. Right, so we take our BMV and we simply pre-oxygenate the patient. Okay, so we'll go ahead and grab our equipment. While the medic's setting stuff up or while we're doing it, whatever, okay, we'll go ahead and provide 5 ventilations. How many ventilations?
5.
So 1, 2, 3, 4, 5. I want to hyperoxygenate. That way I can step off to the side and let the medic do their thing. Okay. Now the whole intubation attempt from start to finish should take about 30 seconds or less. Okay, and we'll see that coming up a little bit later. All right, but I want to give the patient enough oxygen to last that time without becoming hypoxic. Hence why we give those 5 ventilations in relatively rapid succession. Once you've done B, we're going to move on to E, where we assess for any airway difficulties. So we evaluate for airway difficulties while manipulating the patient and opening up the airway. If we're not worried about any type of spinal injury, what position can we use?
Supine?
Well, they're going to be supine.
Head.
Head to chin lift. Okay, so we'll go and hyperextend that head, right, to go ahead and try to get a nice view. So as far as why we do the head to chin lift, again, I want to make a nice straight line from the mouth going all the way down to the lungs by hyperextending the head. Okay, if you got a patient supine and we're going to intubate, again, that nice straight line makes it easy for us to look right through to where we need to go. Do I have that option if they have spinal injuries?
No.
No. Okay, and if that's the case, we have to do the modified jaw thrust, where we got to get that tongue up out of the way. Okay, it's going to make it more difficult to actually visualize the airway when passing a tube. Okay, so if we can, crank that head back, do a head to chin lift, and then we go ahead and attempt intubation, which is, hey, attempt first pass intubation. It's like, okay, cool, we open up the airway, I'm visualizing, I see the vocal cords, try to pass the tube through. Now, if we get it right the first time, then we go to C, where again it's BMAC. So we can confirm successful intubation by ventilating the patient or using other secondary confirmation devices. Okay, so we confirm successful placement by ventilating and or using secondary confirmation devices. We'll talk about a little bit of those in a second. If we don't get it the first time, then we fall back to GI, where we use a supraglottic airway, which just means it goes above the epiglottis. So that could be an example of an OPA. Or an intermediate airway, which we'll talk about in a little bit as well. Okay, so we can't go back and use the endotracheal tube in most places. They say, all right, you screwed up that one time, let's do something a little bit easier. All right, a little bit more sure shot. Right, and then we just go back to C. Confirm successful intubation with either the supraglottic airway, which technically is an intubation, but make sure the airway's good, or if we are using the intermediate, make sure it's working well. Okay, and then from there, if the patient's in cardiac arrest and we have an advanced airway, what kind of CPR are we going to do?
Modified CPR?
Nope. What kind of CPR? If they have an advanced airway and they're in cardiac arrest, what kind of CPR are we going to do? Asynchronous. And what is asynchronous CPR?
Continuous compressions with one breath every 6 seconds, or if it's a PED, it's one breath every 2 to 3 seconds.
Okay, so how long am I doing those compressions for?
Forever.
So
Or
until
every
my
six- for 2 minutes until the AED cycles.
Right, for 2 minutes. Not forever, because then your patient's a puddle of goo and it's still pushing. Okay, right, we're going to do non-stop compressions for 2 minutes. How long?
2 minutes.
How long?
2 minutes.
Right, well, we ventilate at the appropriate rate. So for an adult, we ventilate at a rate of 1 breath every
6 seconds.
Whereas peds and infants, it's 1 breath every
2 to 3
2
seconds.
to 3 seconds. Okay, and we just go and reassess our patients every 2 minutes. If the AED is there, then the AED will be our timer. Otherwise, we use our what? We use our watch, right, and we just go back and reassess after those 2 minutes. Okay, same thing goes for the intermediate airways. For BLS, those are considered advanced, so we do the same type of CPR. Now, as far as equipment, we got pretty much everything we need here. So we're going to need suction, just in case the patient does have an intact gag reflex and they yak, right? We also have to worry about soft tissue trauma. Okay, so the patients may be bleeding, so we want to suction out blood. We need a stethoscope to confirm placement if it's in the lungs or in the stomach. Okay, we'll have one of our secondary confirmation devices. So in this package is what's known as a colorimetric device. Talked a little bit about it way back in respiratory. Okay, but that's going to be this thing right here, one example of it. All right, so with this, it's going to clamp onto the end of the tube, and we can use our BMV to clamp onto this side and provide ventilations. So this paper right here is going to change when it's exposed to patients' exhaled gases, right, when they've been intubated. Okay, so it's essentially litmus paper that will change color when exposed to acids, right? And they'll pretty much match it around the ring around the outside here to be like, okay, our patient's this color, so they may be a little acidotic, maybe a little alkalotic, or they may be within normal limits. Okay, so they'll have these things here. They'll have other ones we'll mention in just a bit.
What was that called?
It's a colorimetric device. All right, we're going to need our stylet as well as tube, sterile gloves because it's going to the lower airway. So this equipment has to be sterile. All right, suction equipment, same deal. We have our laryngoscope, right, handle as well as the blades, forceps, lubricant, what's known as a tube tamer device. Okay, which is going to be this bite block here that goes in the patient's mouth, and we use this thumb screw to go ahead and screw in the tube to hold it in place. All right, so I can't remember if this guy takes it or not, but I'll try to show you once we intubate. All right, now as far as the blades for the laryngoscope, there are 2 different styles. There is the Macintosh, or the Miller blade rather, which is a straight blade, and the Macintosh blade, which is a curved blade. Okay. So, Miller blade is straight, Macintosh is curved. They range in sizes from 0 to 4. The smaller the number, the smaller the equipment. Okay, so this here is a 4 of the Miller. Okay, so this is what you can use for like NBA players that are massively huge, right? Same thing with our McGill forceps, or sorry, Macintosh blade. And here we have 1s. So we'd be using these on pediatric patients. Okay. Now, as far as other terms for these, we call them the straight blade and the curved blade, obvious reasons. Okay, easy way to know the difference, right? This looks like one of the L's in Miller, whereas this looks like the C in Mac. Right? They are going to have light bulbs on the end of it as well, okay, so that we can actually visualize into there and see what's going on. The newer ones have fiber optics, right, where we can go ahead and do that and visualize. Right? Even fancier ones have little LED monitors where they don't have to look in the airway. They just, and just pass it that way. All right. So, when it comes to the tube itself, so they call these Murphy tubes because this guy Murphy was super smart and they didn't know anything back then. Basically, it's a straw. That's all it is. Right? So if I could go back in time, I would make this and not have to worry about anything for the rest of my life. Right? Actually, let me grab a better one here. So, this is pretty much what it is. So again, it's a straw. We have an open end right here, right? We have another open end here, and we have what's known as Murphy's eye right here off to the side. And the reason why we have this hole here is if it's pressed up against something, at least air can still go out through the side. Okay? They call this end the machine end because that's where the BMV goes. They call this the patient end because it goes where?
In the patient.
In the patient. Okay? There are going to be a series of marks that go along the side, and that indicates the depth of the tube in centimeters. Okay? We have a cuff right down here with a pilot balloon up on top. Now, because this is in the patient, when this cuff's inflated, can I see it?
No.
No, but that's what the pilot balloon is for. Okay, so when this inflates, that tells me that the cuff is inflated as well. All right, here we have our stylet. So it's just a flexible tube that provides some rigidity for the actual tube itself. All right, so again, super duper simple piece of equipment, right? But quite effective at what it does. Now, because this is going to the lower airway, this has to be what?
Sterile.
Has to be what?
Sterile.
Now, medics are not always going to be using sterile gloves when using this piece of equipment, okay? Because this part stays out of the patient, does it have to be sterile?
No.
No, okay? So you may see a medic not put on sterile gloves, right, when handling the ET tube, but they're going to grab it from up here, not from down here. Okay, and if you're assisting the medic, right, with intubation, you have to keep this what?
Sterile.
Sterile. But again, you can use your non-sterile BSI to handle it from this side. Okay, but if you go, all right, medic, here you go, okay, they're going to yell at you and tell you to do it again, okay, because you need to make sure that that part stays nice and sterile. As far as lubricating, we can just go ahead and dump lubricant into the package because this package is what?
Sterile.
Sterile, right, and then just pass it through and then hand it off, right? Usually you'll want to hand it like this so they can grab it from you and then go ahead and insert it that way. Or just leave it in the package itself so they can go and pull it out. Right? So that's what we have going on. As far as the tube to teeth mark, pretty straightforward. Okay, we want it around the 22 centimeter line. Okay, so that means about 22 centimeters, whatever that happens to be in inches, right, is going to go down inside the patient. Okay, and if they go too far, that's going to cause one of our complications we'll talk about in a bit. All right, as far as diameter, okay, it's measured in millimeters. And they'll just use the numbers. Hey, give me a 7.5 tube. But the inner diameter of that tube will be 7.5 millimeters. Okay, so for male patients, a little bit bigger tube, but a less larger range, going from 7.5 to 8.5 millimeters. For female patients, smaller tubes, but a bit more range, from 6.5 to 8. All right, and the medic is going to be the one calling out the size of the tube. So once they visualize, like, it looks about a 7, right? And they'll call, hey, give me a 7 tube. All right, and we just go and grab it, set it up for them, and then they go and intubate. Now, as far as pediatrics, okay, we're going to use one of those two pieces of equipment I showed you yesterday, either the Broslow resuscitation tape or the petty wheel, okay, where they'll pretty much line it up against the kid, be like, okay, this kid's yellow, so therefore I need to use this size piece of equipment. All right, or again, they'll dial it in on the wheel, okay, this kid weighs this much, therefore I need to use this size piece of equipment. So when it comes to the stylet, again, it's a rigid piece of metal that will give some rigidity to the tube. The syringe is what we use to inflate the cuff with air so we can create the seal. So that balloon's going to fill up, and it's going to fill in the space around the trachea. That way nothing can come up, right, and nothing can go down into the lungs. So the patient does end up vomiting. We're not as worried about it because that tube, right, is acting as a straw going from the environment or the BMB down to the patient's trachea. Right, so it's almost like a snorkel, if you will. Right. Other equipment, so we may need these McGill forceps. So these are what the medic can use to pull things out of the lower airway if they're visualizing. Okay, can we do any blind finger sweeps?
No.
No. Okay, we can't visualize until lower airway. But a medic, they'll use a laryngoscope to open up, be like, oh yeah, I see a little piece of meat that's in there. They'll take this, pluck it out, and then pull out and relieve that airway obstruction. All right, so again, these are curved to be able to go in to the actual airway itself, right, and grab whatever we need to. And they do come in different sizes. We'll need one of our secondary confirmation devices. We'll talk about the next slide. C-collar and backboards for those that have suspected spinal injuries. Okay, and if they do have that spinal injury, can I crank back on their head?
No.
No. Okay, you want to do that modified jaw thrust. So here's another example of the telemetric device. Does the same thing, just this one's round instead of that one being rectangular. All right, same basic principle. If ALS is there, they're going to have their cardiac monitor, right? And they can look at different things besides just EKGs. So as far as the EKG, so usually green is going to be the actual EKG itself. right? They'll have different vitals and different colors all around here. Blue is usually going to be indicating SpO2. Okay, so they'll be looking at that. And then orange generally refers to carbon dioxide if they're measuring CO2. Now there's two different ways they can measure it, and both are displayed here on the monitor. So this is capnography, where it's shown as a graph. And right here they have capnometry, which is shown as a number. Okay, so they can assess it via capnography by looking at a waveform. And based on the shape of those waves, they can be like, all right, because it looks like this patient might be a little acidotic, might be a little alkalotic, or it looks about normal. Or they can look at the number, which we call capnometry, and they can either have it set to partial pressure of CO2, right, so how much is actually in their exhaled breath, or percentage, right, of how much is coming out. Right, how much of our exhaled breath is CO2? What percentage? 5. Yeah, we exhale 5% CO2 because our body only uses 5% of the oxygen, right? And we blow out 16%. Okay, as far as partial pressure, it's somewhere between about 35 to 45 millimeters of mercury, something like that, if I remember correctly. Okay, so they'll be looking at that too and say, okay, we're somewhere between 35 and 45. Looks good to me. Or if it's too high, that tells me the patient's acidotic. If it's too low, they're alkalotic, okay, which may cause issues. And based on how much CO2 is coming out, they can tell if the patient's been down for a while, because if they're not breathing, they're producing a lot more what? Acid, a lot more CO2 because they can't get rid of it. Okay. Now there's other factors that can throw that off, right? Because just like our chemoreceptors, it's not necessarily CO2, we're just assuming it's CO2, but they're really measuring levels of acids. So if our patient were to overdose on a drug like, let's say, aspirin, okay, these numbers are going to be thrown off because aspirin's a what?
Acid.
It's an acid. Okay, or if they were to overdose on Tums, would the number be thrown off?
Yes.
Yeah. Okay. So again, we're using it just as a guideline, like, okay, this is what might be going on. That's why we treat the patient, not the monitor. Okay, we treat the hopefully living person that's in front of us, not what the machine tells us it thinks is going on. Okay, because can the cardiac monitor be incorrect? Mm-hmm. Absolutely. All right, again, not 100% guaranteed. So as far as actual best way to know if we're in where we need to be, it's through visualization of the vocal cords. Okay, so these are the cords, and right in there is a trachea. And if we see the tube going into those cords and not going too far, we know we're good. Okay, another way to tell is with equal bilateral chest rise and fall. Okay, so the patient should have equal bilateral chest rise and fall. Because if I shove that tube too far, I'll have unilateral chest rise and fall. All right. Now, once the tube has been inserted, we don't want to let go until it's been secured with the tube tamer. Right? If we were to put the tube in and I attach the BMV and be like, all right, cool, we're good, and I let it go, the BMV is heavy enough to where it might yank that tube out a little bit, right, and not have a secure airway anymore. Okay, so we want to hold it in place until it's been secured with one of those tube tamers there. All right, remember, this is going to be going to lower airway, so we want to try to follow aseptic technique as best as we can, especially if we are suctioning. If we are suctioning a lower airway adjunct, okay, such as the ET tube, we must wear sterile BSI. Okay, because we're going to feed it down that tube until it gets to the end, and then when we suction, do we suction the way in or on the way out?
Way out.
How long for an adult?
15 seconds.
What about kids?
10.
Infants?
5.
Right. Okay, and it's pretty much going to be the whistle tip that we talked about in respiratory. So it's going to have 2 holes on the side. So as you're pulling out, you want to twist it a little bit so we're suctioning up any secretions that might be stuck in the airway. Okay, and then once you do that, rinse it out, and then we go and repeat after 2 minutes as needed. All right. So lung sounds should also be equal. Okay, notice I didn't say clear. Okay, this should be equal. Right, because our patient can have rails and the bases bilaterally, but at least we know they're the same. But if I were to hear it unilaterally, I hear sounds on one side and I don't hear anything on the other, okay, that might be an indication of the tube going too far, or it could just be a tension pneumo. Right, so we have to kind of think about it. All right, do I see the other signs of a tension pneumo? Is there a tracheal deviation? Do I see JVD? Am I feeling that snap, crackle, pop? If it's not there, shit, they probably went too far. And we'll look at the tube to teeth mark, and if it's at 28, yeah, they definitely went way too far. Okay? So, when we're doing this, again, we want to pre-oxygenate, so that's where we're going to step in. We'll do our 5 rescue breaths. All right. Once we do that, we step off to the side, and then the medic's going to go and start prepping for intubation. Again, the whole thing should take no longer than
30 seconds.
no longer than
30 seconds.
So we want to give as much oxygen as we can so they can last those 30 seconds. If it takes longer than 30 seconds, they have to abort, and then we go back to ventilating, and then they'll have to wait a few minutes before they do it again. Okay, but that's where we get to the GI, where they have to use a supraglottic airway or an intermediate airway. Okay, they probably won't allow them to go back with an ET tube. All right, way back in the day, they were given unlimited tries with the ET tube, but now they're like, yeah, you're screwing up the first time, so just go for something a bit easier. Right, so there we can see them, right? They're going to visualize, so they're doing it through direct visualization. As I said, there's newer ones that have an LED monitor at the base of the handle, so they're just doing this, watching it through a TV screen, and just dropping the tube that way. All right, other hospitals will have it up on the bigger monitor, so the doctor's not even looking at the patient, right? They're looking at the monitor instead. So when it comes to some complications, okay, we'll go over a few of these. First one is intubating the right main stem. And the reason why it's the right main stem over the left main stem, what's taking up space on the left side of the heart, or the chest? Heart. Okay. So that left main stem is going to have more of a curve going to the left lung. The right main stem is a bit more straight. So that tube's going to favor the right side because it doesn't have to do this weird awkward angle to come this way. It just goes down to the right side of the chest. And then we have that unequal chest rise and fall. Okay, not the same as paradoxical movement, because paradoxical means what? In this case, it means opposite. What does it mean?
Opposite.
What does it mean?
Opposite.
So one goes up, the other goes
Down.
down. Okay, but if we intubate the right main stem, one goes up, the other doesn't move. Okay, so we get unequal chest rise and fall. Now, this is a very simple fix. All we have to do is pull it out just a little bit till we get equal chest rise and fall. All right, another one is intubating the esophagus. All right, so now when we ventilate, where is that air going to go?
The
It
stomach.
goes in the stomach, which leads to
Gastric dissension.
gastric dissension. Okay, and it doesn't take a lot to ventilate, as you'll soon see when we get to the stomach. Aggravating spinal injury, so again, if you try to pull back to a head-toe chin lift, or if you're using the laryngoscope and you hyperextend that head, right, that is going to cause further complications. Taking too long to ventilate, causing hypoxia. Patients having a gag reflex and vomiting, or causing gastric dissension and causing the patient to vomit. Either one of those would be bad. Soft tissue trauma as well, right? Because we are putting a metal blade into somebody's soft tissue, so there usually will be some blood. Okay, so we want to have some suction equipment ready to go so we can suction out whatever blood might be there. There could be mechanical failure of the tube itself. So, for example, if I were to overinflate the cuff, it would rupture, and now we don't have a seal. Okay, so we don't want that to happen. Patients become intolerant of the tube, bless you, okay, where they may regain consciousness and try to pull that tube out. All right, and then finally we have a decrease in the heart rate. So remember, we have a total of 3 nerves that we talk about in this class. Okay, we've already talked about 2. We've talked about the phrenic nerve as well as the oculomotor nerve. All right, Mr. Fox, what is the third nerve?
It's one that controls the diaphragm.
No, that's the phrenic nerve. Ignacio? No? George? No? Cheyenne?
What was the question?
What's the third nerve that we haven't talked about yet? So we've got the phrenic, we've got the oculomotor nerve, the vagus nerve. What is the vagus nerve responsible for?
It's not body.
I'm sorry?
It's not body.
No, it's not body movement. What's it responsible for? What's it responsible for? Erica?
Sending signals to the body.
Okay. What signal specifically?
CNS signals.
Okay, well, it's going from the central nervous system to the rest of the body, yes. But what response is it responsible for?
Sympathetic.
Nope.
Parasympathetic.
Parasympathetic. Okay, so the vagus nerve is what's going to send signals from the parasympathetic response to function. And that's why if our patient has severing of the spinal cord, causing what kind of shock?
Neurogenic.
Talking to you. What kind of shock? What kind of skin signs do they have? Axal and only axal.
If they went through a neurogenic shock, it'd be maybe two-tone.
Two-toned. So what skin signs would they have below the injury? else? Below the injury.
Warm.
Okay. And?
And would it be clammy?
No.
It'd be dry.
Why would they be dry?
Because your sweat glands need signals from your nervous system to secrete sweat.
Right. Okay. So that patient's going to be warm, flushed, and dry right below the injury because their body can no longer get signals from the brain, right? As far as central nervous system. However, the parasympathetic messages can still get through because the vagus nerve originates where? No, in the brain. It's a cranial nerve. Okay, so it originates from the brain and then travels throughout the rest of the body. That's what we call the vagus nerve because it's like a vagrant, right, that travels everywhere. Okay, so it's going to have effects on pretty much every single part of the body from your brain all the way down through to pretty much your colon. Okay, so that's why we get those parasympathetic signals when the spinal cord itself has been severed because we need central nervous system input, right, for us to activate the sympathetic response, right? Now, if our patient were to gag, okay, that is going to activate the vagus nerve because it's basically a baroreceptor, right? And that's why I also had you guys way back when check your pulse and bear down like you're constipated, right? Because that's stimulation of the vagus nerve. And we call those vasovagal episodes when patients are doing that and they pass out, okay? Now, if our patient has an intact gag reflex, gagging activates the vagus nerve. So if you were to intubate and the patient does that, okay, they put pressure inside their chest, stimulating the vagus nerve. Because it controls the parasympathetic response, what happens to their heart rate?
Slows down.
It slows down. And if these patients are being intubated, do you think they're going to tolerate bradycardia? No. So what can happen?
Die.
They can die. Okay? So we got to be really careful about that. And that's why sometimes medics, depending on their scope, they have to actually sedate the patient and paralyze the patient to actually intubate so they can suppress their gag reflex. Right? Now here in LA County, they don't do that. Right? They're not going to allow them to sedate and paralyze somebody to intubate. They're like, hospital's 5 minutes away, dude. Just take them. Right? And the doctors, they're the ones that get to go and do that stuff. Okay? But again, other places, they may do that. And if the patient does have a gag reflex, this is the main thing we're worried about. Okay? It's causing them to gag, possibly throwing up, yes, but also stimulating that vagus nerve, causing bradycardia.
Would that happen? Is that what happens when people pass out on roller coasters?
It's a little bit different. That's more looking like psychogenic shock. Right? But if they're doing that, we'll talk about it as well. But old people, right? Do old people always go very well when they're on the toilet? No, that's why I gotta drink that prune juice. Right? That's why they'll sit there and then go out. Right? That was an overdose. So
I thought he died from like pushing too hard.
No.
that's an OD.
We'll
We'll talk about that with geriatrics. All right. So again, once the patient has been intubated, okay, then we go and start doing asynchronous CPR. So, as far as what the intubation procedure is going to look like, okay, going through B-Magic, first thing, we perform BMV, well,
Oxygenation.
pre-oxygenation, okay, so we go and give those 5 ventilations, 1, 2, 3, 4, 5. We'll step off to the side, and then medic's going to come on in, right, and they're going to go ahead and get their equipment set up and ready to go. So you're going to take the laryngoscope, right, and they're going to insert this into the patient's airway, right? And they're going to go ahead and open up like so and visualize. Go and pull this off for me, please. And visualize the airway, right? And they're going to go ahead and try to pass this through. So I'm going to go for esophageal placement first, all right, so we can see the different complications. So we'll say they couldn't see the vocal cord, so they just shoved it down, right? And it landed into the esophagus.
You can see it.
So seal that up there, pop that off, hook this up here, and then we go and provide ventilations. Okay, 1, 2, puke. Okay, and that's how easy it is. All right, so we got to make sure we're ventilating just enough until we see equal chest rise and fall. Okay, if the medic has accidentally intubated the esophagus, right, they have to deflate the cuff. Where did my syringe go? So deflate the cuff, yank it out, and then they go for GI. Okay, so go for the supraglottic or the intermediate airway. So next one, we'll go ahead and try go for right main stem. The light doesn't work on this, so I'm just using the light from the class. But we'll say that's it right there. So we're going to go as far as we can. So we're at about 29, 30 centimeters in, where we should be at what mark? 22. So we inflate that, peel it off, hook up our BMV. right? And there we have, right, intubation of the right main stem. Now this is an easy fix. What do?
Pull out.
Pull it out to what mark?
22.
22 centimeters. Okay, so we go ahead and deflate the cuff. You got to make sure you deflate that cuff. Pull it out to 22. So there we go. All right, then reattach, and now we have equal chest rise and fall. All right, so obviously hyperventilating, but again, we'll see that equal chest rise and fall going on there. All right, and obviously if I see the lungs inflating, we got a problem. So instead, I go and auscultate and just do rapid auscultation to confirm that we're actually in the right spot. Okay, so mid lobes, cool. Got lung sounds, we're all set. All right, and then we just go ahead and ventilate at 1 breath every
6 seconds.
for what kind of patient?
Adult.
What about kids?
2 to 3
Right, 1
seconds.
breath every 2 to 3 seconds. Now, if we were not successful with intubation, okay, again, move on to GI. So one of the other airways we can use is called a multi-lumen airway. Lumen is just a tube. Okay, so multi-lumen airway is a multi-tubed airway, and this is an example of that. The brand name for this is called a combi tube because it's a combination of 2 tubes. Right? Now, the combi tube has its pros and cons. The good thing about a combi tube is we don't have to visualize the airway. Okay, so in places, BLS might be able to use this over an actual endotracheal tube because we don't have to see. We just shove it down the patient's throat, and whichever tube it lands in, be it the trachea or the esophagus, this will work. All right. The downside to this is that we have to be really careful about listening to lung sounds because there's 2 different tubes that are going down. One of these is essentially an ET tube, right, where it's a straw that goes from one end to the other. The other one is part of what's called a King airway, and we'll talk about it after the combi tube. But we're going to have these vent holes right here along the side. Okay, so if I ventilate the wrong tube, we may cause gastric ascension and not realize that we're putting air into the stomach instead of the lungs. All right. The other downside is we can't use it on smaller, younger patients. Okay, so we can't use it on kids less than 16, 1/6, or patients who are shorter than 5 feet. Okay, so patients who are shorter than 5 feet or under 16 years old are contraindications for the combi tube, as well as patients who have ingested any caustic substances like acids, alkali, or anything like that. So if they drank a bunch of bleach, we can't use the combi tube. All right, we also cannot use it for patients who have esophageal diseases such as esophageal varices. Chris, what is esophageal varices? What is it? Erica? Charge? No? Donna?
I thought we don't have the little. Is that the epiglottitis?
No, because epiglottitis is epiglottitis.
Inflammation of the esophagus.
That's esophagitis. Axel?
Can you repeat it?
What are esophageal varices?
Is that when the filters aren't there anymore?
Strep throat.
No.
Trauma to the esophagus?
Nope. Not sure.
It's not the hair from the
No, because that's COPD bronchitis.
Would it be like ulcers or things that like make the esophagus sensitive?
No. What is it?
It's inflamed esophagus vessels pop and bleed.
Right. Okay, it's the blood vessels in the esophagus. Okay, they're distended and can rupture. Right? And if our patient has ruptured esophageal varices, can that be fatal? Yeah, because there's nothing we can do about it. Okay, because they will bleed and bleed and bleed and bleed and bleed. I can't have them swallow a bunch of 4x4s to stop the bleed, and I can't wrap around their neck either to control the bleed. Okay, if we suspect they have esophageal varices based on their history, okay, we don't use combi tubes, right? So if a patient has, chronic alcoholism, right? They have things like hepatitis, where I know their liver's jacked up, okay, that blood's going to start backing up through different blood vessels, goes be in the esophagus. Okay, so we hold off on the combi tube because, again, it can go in the esophagus and still work. So that's what we have. Again, we got 2 different cuffs. You guys saw that up there. Now, as far as how it works, okay, again, it can go into either the trachea or the esophagus and still function. Okay, So more than likely, it's going to end up in the esophagus because the esophagus is more of a direct line going from the oropharynx down, whereas the trachea is more anterior. Okay, so if our patient's laying supine like they are here, the combi tube essentially has to curve upwards to get into the trachea, right? Where it's an easier straight shot to go down to the esophagus. Now, if it does go down to the esophagus, okay, that's where these little, what I like to call flute holes, okay, are going to come into play. So we're going to go ahead and choose the longer tube first because that's going to go all the way down through here and open up into those vent holes and force air into the trachea. Okay. Now, if I go for the part that's essentially an ET tube, okay, it's a straw that'll go from here, and then I'll be forcing air directly into the esophagus, which means it's going to go where?
To the stomach.
And then cause.
Gastric
And then what's the patient going to do?
Throw up.
Right, and now we have a fountain, okay, where all that puke's going to start coming out over here. Now, because the tube is more likely to end up in the esophagus, okay, we're going to start with tube number 1, which is going to be the longer tube, and they are numbered. Okay, I'll pass it around for you guys to go and take a look at in a second. Okay, but I hook my BMV up there and I ventilate, so it starts coming out of the side here. All right, now if I do also take gastric sounds, right, or there's no chest rise and fall whatsoever, okay, then we know we're in the wrong spot, right? Then I'll switch over to tube number 2, which indicates that we got placement in the trachea, okay, which is what we see right here, okay? So if I were to use this, I'd ventilate, maybe get a little bit of air going down into the esophagus, getting gastric sounds, or it may be pressed up against the actual trachea itself, if the holes are up there, and we don't hear anything at all. Okay, so then we go, okay, that didn't work. Go to tube number 2, and that's going to push that air all the way through to the trachea. Okay, so the benefit of that is, again, it doesn't matter what tube it ends up in, we can still provide effective ventilations. The downside is it's a 50-50 shot, and if you choose the wrong one, you might cause gastric ascension. Okay, however, even though it sounds really good on paper, they actually don't really like using this anymore because we have an easier, better alternative. Okay, and we'll talk about that. So, contraindications, right? Esophageal diseases like esophageal varices. Okay, but cancer and stuff like that, we don't want to use the combi tube. All right, those who've ingested a caustic substance, so stronger acids or alkali, because they will corrode the cuffs and no longer have a seal. Okay, we can't use it on patients that are shorter than 5 feet or kids younger than 16, because patients that are that small and that young just don't have big enough airways. All right, and of course, if they have a gag reflex, we're not shoving anything down anybody's throat. Now, when it comes to the other airway we can use, okay, that'll be the king airway. So this is the king airway, okay, and this is going to be the part of the combi tube that has the flute holes, because on the king, that's where we have the flute holes. So all the combi tube is a combination of the king airway, basically duct taped, right, to a ET tube. That's all that this is, right? Now, the reason why they prefer this is because it's super easy. All I do is just shove it down the patient's throat, it goes in the esophagus, and that's it. Right, whereas the combi tube, again, okay, is it in the esophagus, the trachea, which one is it in? This is, you put it in, it's going to be where it needs to go. Okay. Now, as far as LA County, okay, they don't let us use this because they don't let us do anything, right? But this is kind of what they're replacing ET tubes with as well for ALS. So they may say, hey, just go for the king instead. Some circumstances, you may go for the actual ET tube itself. All right. So again, it goes down to the patient's airway. We have our cuffs that will seal off. So this seals off the upper airway, so air can't come back up this way. This will seal off the esophagus, so air can't go down in and cause gastric ascension. And those flute holes that are right here force air to go up and down into the trachea itself. All right, now for this, all you have to do is just run it along the top of the patient's mouth, and it's going to go right where you want it to go. There are different sizes, so we can use these on younger kids as well. Right, so pediatric patients, as long as they're taller than 4 feet. Okay, so we can use it on smaller people. Gotcha.
On this, why we're using these type of areas, like instead of a BNB or CPAP or anything?
Well, because the patients aren't breathing, so we have to use this stuff. All right, CPAP doesn't work if they're not breathing. BMV will breathe for them, but I'll just hook the BMV up to this and ventilate for them. Yeah.
So for like small people, like little people, if they have like a normal sized chest with smaller like appendages, can you still use these technically?
Well, it's all about the anatomy of the inside, right?
What does
So-
it say? Like it's not like mid, it's like small.
like smaller stature people, yeah.
Yeah.
I mean, it's fine. So it's all about diameter. So it doesn't matter. That's why there's no age specifically for the king airways. Are they taller than 4 feet? If they are,
Oh,
cool.
it's the diameter. I thought it was length.
Right. So we'll go and drop that in, right? And we'll just go and ventilate as needed, and we'll just use it as an advanced airway. So ventilate 1 breath every 6 seconds, 1 breath every 2 seconds for kids. All right. For CPAP, continuous positive airway pressure. We use that for patients who have pulmonary edema or severe bronchospasm. Right, and I use that continuous positive airway pressure to force open the smooth muscle in the case of bronchospasm, or to force out the fluid from the alveoli in the case of pulmonary edema. Okay, we have to use it with caution in patients who have COPD, especially emphysema, because I do want to inflate the alveoli a little bit, but because they're weak, there's a high risk of them doing what?
Pumping. Yeah.
Rupturing. Right? Yeah, exactly. Okay, so we got to be very careful with those COPD patients. Now, as far as the amount of oxygen that's coming out of CPAP, it's equivalent to about 50 liters per minute. So there's a lot of oxygen going through that to maintain that pressure. All right, and we're not going to hook CPAP up to the Christmas tree because the regulator only goes up to how far?
25.
25. Okay, but if you guys have bothered looking at the regulators, okay, there's a threaded portion, right, where we thread on the CPAP, and that's where it goes because it's going to tap exactly what it needs from the tank itself. Right, whereas the Christmas tree, we have to set the flow rate.
So for the CPAP, I was wondering, can we attach that to an advanced airway? Because if it's just a mask, can it cause distension in the gastric area?
That's why we don't use it on unconscious patients because they can't maintain that, and the body will automatically kind of keep air from going into the stomach. Right. As far as CPAP, we won't hook it up to an advanced airway. We use something similar. It's called an oxygen demand valve. They don't really use it a whole lot anymore, but you hook it up to the mask, and then you manually trigger by squeezing this lever, and it shoots air into the lungs that way. Right. Because CPAP's continuously going, there's no way to regulate. Easy way to blow out your lung. So with the demand valve, we are in control of that. All right. Now to reduce some other issues, there's BiPAP, where it's going to be happening at certain points. So it's not continuously pumping air. Depending on settings, it may be upon peak of inhalation or peak of exhalation where it shoots in a burst of air. So if it's set to inhalation, as the patient inhales, at the peak of inhalation, it's going to detect, okay, there's this amount of pressure. It's going to shoot a bunch of air to hyperinflate those lungs, right? Or at the peak of exhalation, it's going to shoot a little bit of air to keep those lungs inflated so they don't collapse. So it saves oxygen, so it's not continuously flowing through, and it reduces the risk of gastric distension, right? But for CPAP, we need that constant pressure, right, to start moving fluid out or opening up the smooth muscle. So that's an example of a CPAP mask, very, very tight-fitting mask that goes around the patient, okay, that's again forcing a lot of air into the patient's lungs to move stuff out of the way. When it comes to nebulized albuterol, okay, here in LA, we cannot give nebulized albuterol as EMTs. Again, even though, as displayed in the picture, some of you, right, kids can do it.
Yeah.
Okay? Again, that's why LA County does not trust you with sharp objects around babies, because they don't trust you with skills that kids can do for themselves. So, as far as nebulized albuterol, there's 2 different nebulizers that we can assist the medics with, because again, after all, we're medics' little what? Helper. So they may go ahead and give nebulized albuterol. So we'll go ahead and screw this top portion off. We'll take one of our albuterol containers. Depending on the dosage, the medic may ask us to put in 1 or 2 of these things. We'll go and reassemble this, screw that back on, take the oxygen tubing, hook it up to the bottom, and we're going to set it to a flow rate of 1 to 4 liters a minute, 4 to 6 liters a minute. All right, so it's going to be one of those numbers. So 4 to 6 liters a minute. Okay, hook it up to our Christmas tree, and it's basically going to make an aerosol of whatever's inside. Okay, we go and take our T-valve, put the mouthpiece on, vent tubing, and then, legally speaking, I give it to the medic, who then gives it to the patient. Okay, because again, we cannot administer nebulized albuterol. Okay, but just like finger sticks, is it always going to work that way? No, we did all the work. Medic's like, yes, give it to them. All right, so we go and hand it to the patient, have them put their mouth around it, and just tell them to breathe normally. Okay, and for those of you that had breathing treatments as kids, that's all that this is. All right, so just put it on and just have them breathe normally. right? And that's it, we'll reassess. Okay, so in the case of a meter dose inhaler of albuterol, one of the contraindications, besides them not being able to follow simple commands, is if they've what?
Gag reflex.
Taken their max dose.
Oh.
Close, sir. All right, if taking their max dose, we can't give them nebulized albuterol. But when ALS shows up, okay, kids got respiratory distress, they got wheezing, here we go. Right, they can go ahead and set up and give nebulized albuterol. Right? So again, it's a relatively safe drug. We just want to keep on going and going and going and going and going. ALS will be able to give this and give as much as they need. Okay, so here's another step in nebulizer. Works in a very similar fashion. We unscrew this portion, drop the medication in, screw this part back on. So venting will be done from the top. Mouthpiece goes here. Hook it up to 4 to 6 liters, right? And then we go ahead and give to the medics to give to the patient. All right. As far as the EKGs, so we have different types of leads. We have 3 leads that have 3 stickers. We have 4 leads that have 4 stickers. And we have 12 leads that have 10 stickers.
Right, you told me.
So, as far as 3 leads and 4 leads, we'll go over those first. Okay, these are just basic EKGs, right? Where the medic's going to get a somewhat decent picture, quote unquote, of the heart to kind of see what's going on. It's not super detailed. It's just, all right, let's see what's going on with the heart. If there's any electrical abnormalities, right? We'll go and put it on. Now, as far as the 3 lead and 4 lead, we have a little phrase that we use for placement. Okay, it is white on right, smoke over fire, and if we're doing 4 lead, clouds over grass. Ramon. Okay, so white on right, smoke over fire, and in the case of a 4 lead, clouds over grass. All right, now there are proper placements of the leads, right, where they should go, but medics will sometimes put them in different places, and they serve different functions. Now, as far as the white and black leads, okay, they're just mirrors of each other. So white goes on which side? Right side. Okay, but it goes along the mid-clavicular line at about the 2nd intercostal space. Okay, so the white lead goes right here. The black lead goes on which side? Left side, mid-clavicular, 2nd intercostal space. Okay, so one lead right here, that'd be the white lead. This lead right here, that'd be the black lead. Right, smoke over fire. Okay, so we're going to put the red lead down for our 3 leads. Okay, so the red lead would go on the left side of the patient, mid-clavicular, about 7th intercostal space. Okay, and the quick, easy way to identify that, it's going to be at the bottom of the sternum. Okay, so bottom of the sternum is your 7th intercostal space, go to the mid-clavicular line, bam, you put your red lead right there. And if we're doing a 4 lead, green is the opposite. So it's going to go on the right side, 7th intercostal space, mid-clavicular line. Okay, so what you're doing is you're getting 4 different angles, right, of the heart to see what's going on. All right, now sometimes they may want a wider field of view, right, to get a bigger picture but less detailed, so they're going to spread those leads out a little bit. So they may ask us to put it on the patient's shoulders and down by the hips. Sometimes they'll put it on the patient's hands and down by the feet to get super wide angles to see what's going on. All right, so like I said, for our purposes, it just works on voodoo magic. It's able to look and see what's going on with the heart. All right, now when it comes to 12 leads, which we'll get to in a bit, okay, it's going to be a little bit different, but we're still using those 4 leads. We're going to add on a few other ones. So going back over normal sinus rhythm, right, there's going to be P wave for every single QRS, telling us the SN node is firing off. All right, it's the spark before the bang. So we have the ventricles that are contracting with massive QRS complex, the T wave as they're recharging. And when it comes to a patient who's suffering from commotio cordis, again, they have to be hit the exact wrong time during the heart's electrical cycle. And that exact wrong time is right there, right at the upstroke of the T wave. Okay, so if this kid, because kids are freaks and they have that very flexible chest, if they get hit, okay, sternum and ribs cave in, hit the heart, depolarize it, and send it into VFib. Okay, now are we always going to have obvious signs of trauma right on the chest? No. Okay, so we may not have any bruising, any lacerations, any redness when a kid receives chest trauma because their chest will kind of give in a little bit, absorb the energy, and then spring back out. Okay, so we have to just assess the mechanism of injury by asking what happened. Hey, what happened? Oh yeah, the kid took a line drive right to the chest and then just dropped. All right. as far as our defibrillatable rhythms, we got VFib and VTAC. Okay, so VFib is, again, complete electrical chaos in the heart, where there's no organized rhythm irregularity whatsoever. So it's just shaking in the chest like a bowl of jello. With VTAC, okay, the ventricles are pumping way too fast to effectively push blood out to the rest of the body. All right, so when it comes to the AED, Daisy, what is the purpose of the AED? Erica?
To stop the heart and try to reset the electrolytes, stop messing.
Right. Okay, it's designed to stop the heart. Do what to the heart?
Stop the heart.
In hopes that it's going to reset itself. Okay, so that way the SNO can take over and function as its primary job as a primary pacemaker. Okay, so we want to go and zap the patient to go ahead and stop the heart in hopes that it resets. And again, VFib and VTAC are the only rhythms the AED will actually analyze and shock. Okay, now if we are transporting a patient who is in cardiac arrest, guards, what do we have to do when the AED is ready to analyze them? If we're transporting to the hospital?
Continue with compressions.
Nope.
You have to pull over
And?
and wait.
What do you mean wait?
You have to pull over and stop.
Right. Pull over and stop. Okay, not close to 3 miles an hour. Okay, we pull over, we stop, right? Because if that patient's moving around on the gurney, is it able to analyze the rhythm?
No.
No. Again, all the AED sees is this, and it goes, I don't know what that is, I'm not shocking. And then therefore it's not going to defibrillate. Okay? But we also have our non-shockable rhythms, which would be asystole, which is just what? Flatline, and pulse is electrical activity, where there's electrical activity, but there's no pulse. Okay? So if the AED sees either of those two rhythms, won't advocate a shock, it's going to say no shock advised, continue CPR. All right, and we just keep going from there. Okay? Now, as far as patients who are in asystole or PEA, just because they're in those two rhythms or either one of those rhythms, does that mean that they're done for?
No.
No. Okay? Patients can still come back if they're in asystole or PEA. It's just the AED is not going to work. All right? But just because a patient's in VFib or VTAC and they get defibrillated, is that always going to work?
No.
Okay? It's really just a crapshoot. Right? Now, the times that I've gotten ROSC, right, return of spontaneous circulation, where patients are in these rhythms, not VFib or VTAC, even if we defibrillated. Right? So, as far as asystole, again, flatlining, where it's just a dead piece of meat inside the chest where nothing is happening. Okay, we got called out for a patient who was found unconscious with a downtime of 20 minutes. Okay, and this was summertime in San Bernardino. So, is the picture looking good?
No.
Okay, so my medic calls up the hospital, says, hey, we got a female patient down, mid-50s. Last time seen normal was approximately 20 minutes ago. We patched up to monitor, we got asystole. What do you want us to do? My partner's thinking, all right, she's done. Like, oh yeah, go and work her up, bring her to us. Okay, copy. So, we start working her up. 5 minutes of CPR, 2 rounds of epinephrine, she gets sinus attack on the monitor with pulses. All right, so we're like, oh shit. So, call back, hey, we got sinus attack and pulses. We're gonna be there in about 7 minutes. Right? So we load the patient up, we go, we drop her off at the hospital, and we keep running calls. We go back, and we're like, hey, what happened to that cardiac arrest that we brought in? Like, oh yeah, she actually coded, but she got ROSC again. Oh shit, okay, she just doesn't want to die. So we go, run another call, go back to that same hospital because it was our base, and then we ask, hey, what happened to that arrest? Oh, she went up to ICU. As they're saying that, code blue ICU, that's probably her. Right? We finished shift, and I don't know what happened after that. But, again, downtime 20 minutes in the summertime, asystole when we show up, probably brain dead, right? Not much going on there.
Someone ordered some huge favors.
Do you know what like made her drop her? No.
No, we don't know. It was at these, boarding care facilities where they're just there.
Drop off old people.
Yeah. So, that's all that was. Now, as far as the patient who had PEA, we got called out for a seizure. Okay, when most patients go into cardiac arrest, it looks like they're having what?
Seizures.
Looks like they're having a seizure. They'll stiffen up and go down, and that's it. There's no tonic-clonic activity, or clonic activity rather, just tonic. So we get called out for that, and then we're on the way, and then it gets upgraded to a CPR in progress. We're like, oh, okay, it's kind of interesting. So we got there, fire was already there, they were starting to work up the patient, and the roommate who witnessed the actual arrest started doing CPR right away. Okay, so patient was a witness full arrest with almost immediate CPR started. Okay, cool, things are looking good. So, same deal, patch them up, patient's in PEA. About 5 minutes of CPR, 2 rounds of epinephrine, patient comes back. I don't remember what rhythm they were in, but patient had pulses. All right, perfect. So my partner gets the patient intubated. We get him in the hospital. Don't know what happened, but I'm assuming, all right, based on all those factors, witness arrest, immediate CPR, right, quick conversion. We probably made it with very little deficits, if any at all, right? So it's just a total crapshoot. But again, the patients that I've had in VFib and VTAC, every single one of them, even if you defibrillated, they were done, no matter the downtime or anything like that. Okay, so it just really depends on what's going on. Remember, the most common cause of patients who go into VFib is because of what cardiac complication?
Left-sided. What?
Which cardiac complication?
AMI.
AMI,
Oh.
right? Most commonly documented rhythm, right, is going to be VFib if they go into cardiac arrest. So because of those patients, they probably had so much damage to the myocardium, it just didn't matter, right? Whereas these patients, it just got lucky. Again, I don't know what happened to asystole. PEA probably had a heart attack and just was a weird kind of conversion that was going on, right? But again, with immediate CPR, able to pretty much keep that patient as is. Now, as far as the 12 lead, again, is it our job to read the squiggly lines?
No.
But it's our job to put the stickers on the patient. Therefore, we have to put accurate placement of those leads. Okay, we want to give the medic the most accurate picture possible so they can get the best diagnosis of what's happening. All right. Now, they're going to be using the 12 lead to determine if the patient's having an AMI. Okay, so the OPQRST gives us a good idea of what they're having, be it angina or an AMI, but the only way to know for sure is through the EKG. Now, with the 12 lead, they can determine which part of the heart is actually having the infarction, right, by looking at the squiggly lines, seeing what it looks like, and where on the actual chart itself. Okay, so as far as our placement, we have our 4 leads, and again, here you can see they're kind of further out. Okay, they want a wider angle of the heart because the detail is going to be coming from these leads here. Right? So even though it's a 12 lead, how many stickers go on the patient?
10.
10. Okay, so we have the 4, all right, that are going on the right side, right, with the white lead. All right, then we got the green lead, black lead, red lead. And then we have our V leads. So with the V leads, these are essentially attachments that we're going to add on to the EKG wire itself. Okay, so we got a total of 6 additional leads that we put on, and they're numbered. So here we have V2, but again, it goes from V1 to V6. So I'll do the best I can for placement. But as far as V1, okay, this goes on the patient's right side along their sternal border around the 4th intercostal space. So V1 goes on the right sternal border at the 4th intercostal space. Okay, so it's going to go just above the nipple line. So we go and place that right here. V2 is the mirror, so it goes on the left sternal border, 4th intercostal space. Okay, so if you have to, just simply palpate and find where the sternum is, around the 4th intercostal space, and that's where your leads go. Okay, we usually skip the odd number leads for now, because the even number leads have specific landmarks. So skip V3, go to V4. V4 goes along the mid-clavicular line, about 5th intercostal space, so just below the nipple line. Okay, so we put V4 right here. Then, get my hand stretches, we'll go for V6, which will go along the 5th or 6th intercostal space, mid-axillary line right here. Okay, so we go and patch that up there. And for the odd number leads, all we do is fill in the blanks. All right, just connect the dots. All right, we can go ahead and get the different leads. So what we're doing is we're pretty much coming around here, going underneath the pec muscle or breast tissue, right, getting different angles of the heart coming around this one side. Now, a medic may offer or ask for a reverse 12 lead, where they're now looking at the right side of the heart instead of the left side. Okay, now the reason why we focus on the left side more is because the left ventricle pushes blood where?
Everywhere.
To the rest of the body. Okay, and they're more likely to have more serious signs and symptoms with the left-sided AMI versus the right-sided AMI, right? And here they're going to look around the left side and kind of the medial aspect, whereas the right side, looking at the right side, possibly even the posterior section of the heart too, if they're having a posterior AMI on the back side of the heart. All right, so the medic's going to say, hey, patch the patient up to a 12 lead, and then we have to go and put the stickers on the patient. All right, so that way they can go and interpret what the actual EKG is showing. All right, so again, V1, 4th intercostal space on the right sternal border. V2, 4th intercostal space, left sternal border. Skip V3, go to V4. So I'm just trace it out there. There we go. So mid-clavicular line, 5th intercostal space. Skip over to V6, right? 6th intercostal space along the mid-axillary line right here. All right, and then from there, just fill in the blanks. Right, hit print, and then the medic's gonna look at it and be like, okay, here's what we see. And what they really are looking out for is what's known as a STEMI. And a STEMI is an ST elevation myocardial infarction. Sounds super fancy. Right. ST elevation myocardial infarction. Right, so yes, it is a myocardial infarction, but it's happening specifically to the left ventricle. Okay, and we can tell that based on the shape of the EKG complex. Again, is this our job to recognize it?
No.
No. Okay, but we kind of say it looks a little funky compared to our stereotypical ECG complex. So ST elevation is simply because the ST segment is elevated higher than it should be. All right, and that tells us there's something funky going on with the heart right here. Now, nickname for this is called a tombstone, even though it doesn't really look much like a tombstone to me. But just based on the wave shape, right, they'll say that. And also, these things tend to be fatal. So your patient ends up under a what? Tombstone. They end up under a tombstone anyways. All right. So they're going to be looking out for this, right? And these are the patients they have to very, very, very quickly get to a cardiac center so they can receive what medication, Darj? If they're having AMR, what medication do they need to fix it? Well, we would have given aspirin, but at the hospital, what drug would they give them? What type of drug? Right, clot busters. Fancy term for clot buster is what? What's fancy term for it? What's fancy term for it? Thrombolytics.
Thrombolytics.
Okay, so they need a thrombolytic, right, to go and dissolve that blood clot, right, or the clot busters. Okay, so at those STEMI centers, that's where they're going to have that stuff, right, and we want to get them there as quickly as we possibly can, because after all, time is muscle. But when it comes to the brain, time is
money.
brain. No, sir.
You gotta use your brain for that one.
Right. Okay, time is brain,
Time is
right,
brain.
when it comes to strokes. Okay, and with stroke patients, again, they too will be getting thrombolytics, but we'll take them to a stroke center because it's obviously for strokes.
But so if it's on the right, do we just reverse the order?
Yeah, we just do the opposite thing. Okay. Now, as far as patients who may be having an MI, are they always going to have that crushing substernal chest pain going onto the left shoulder and jaw?
No.
What kind of patients are not going to have those signs?
Female geriatric diabetic patients.
Okay. And what are they going to be complaining of?
Being really tired.
Right. And what do we call that type of AMI?
Silent AMI.
Right, silent AMI. Okay, now you have to be able to identify that specific. As far as IVs, okay, they may give what's known as a fluid bolus, which is a large amount of fluid in a relatively short period of time, for patients who are hypovolemic, either due to vomiting or diarrhea, which is the number one cause of dehydration in what type of patient?
Kids.
Yeah.
Kids. Yeah, kids are going to be dehydrated primarily from vomiting and diarrhea. Okay, but also going to be used to replenish fluids in cases of patients who are losing lots and lots of blood. Now, with patients who are losing lots and lots of blood, they're giving fluids to increase pressure, but not really to replace blood. Right? Only blood can replace blood. So what will happen sometimes with these trauma patients is that they're bleeding red, and eventually they'll start bleeding pink, and then start bleeding clear. Right? Because they're replacing all their blood with saline. And saline has pretty much nothing to do with perfusion besides it just taking up space. All right, so that's one thing they do have to be careful of. And a lot of places, from what I've read, are now doing something called permissive hypotension, where they're actually not giving them fluids and they're letting the body compensate for itself, right, by constricting blood vessels and things like that. Because by filling it with fluid, the body's like, okay, we got stuff in our blood vessels, so let's go and open up, which just makes them bleed even faster. All right, LA County doesn't do that. LA County's like, all right, they're bleeding, pumped full of fluid, let the hospital deal with it. Right. Other places, again, ALS may possibly carry whole blood where they can replenish that stuff, but again, not happening here in LA. Now, as far as the actual IV bags themselves, they come in a bunch of different sizes and whatnot. I'll talk about those in the next slide. But they will become wrapped in a plastic bag like this. Now, as long as it's in this bag, it is sterile. It's what?
Sterile.
Okay, but once it's out of the bag, it's no longer sterile. Okay, and once it's out of the bag, we have 24 hours to use the solution. In the field, it's not going to be an issue, but in a hospital setting, right, the patient's on a very, very long drip of medication, right, they may have to swap it out. Now, there's different IV solutions. So here you have lactated ringers, which is saline with some extra stuff in there. Whereas normally, it's just going to be regular plain old saline with just salt and water, right? And normal saline is 0.9% saline, or salt, right, and water. Okay, and that's going to be matching our body salt content. There's other forms of saline, like half normal saline, double saline, where it's going to have more or less salt, depending on what it actually is. So as far as sizes, okay, these are the 3 most common sizes that patients will have, which is really 2 big common sizes, but there's 3 overall. There's a lot overall. So we got our 1 liter bags. Okay, so there's 1,000 mLs of saline in this bag. This bag right here is the 500 ml bag. Okay, and these are the bags we're going to be using for bolus, large amounts of fluid over a relatively short period of time. So this is 1 water bottle, this is 2 water bottles, right? There's also a 250 ml bag, so a quarter or half a water bottle rather, right, is what we have here. Generally, the smaller the bag, right, the more it's going to be used for a medication drip instead of just fluid replacement. Okay, so if a medic just needs to give fluid just to give fluid, well, they'll opt for the larger bags. Okay, but if they're giving certain medications, right, they want a more accurately controlled dose, they'll be using smaller bags. Right, this one is 5% dextrose and water. Okay, so it's a little bit of tiny sugar water that we have inside of this. Right. As far as patients who are hypoglycemic, what do they need?
Sugar.
Sugar, right, glucose. Okay, or glucose, we don't give it if they cannot maintain the airway. So they have to be given glucose via which route?
Intravenous.
Via the IV. Right, in that case, they call it dextrose. And that dextrose is mixed in water. What they used to give back in the day was a solution called D50, which is 50% sugar and 50% water. Basically, it's a simple syrup. Okay, but what they found out is if the medic screwed up that line and infiltrated, and we'll talk about that in a little bit, okay, that would actually cause local tissue necrosis and do more damage than good. All right, so like, hey, you know what? You know, some people are screwing it up. Let's not use D50 as much anymore. And we'd spike up their sugar, and just as quickly as it went up, it would go back down. So they're like, hey, let's do 10% dextrose or D10. Yeah, it may not fix them as quick, but the complications are less severe. Right? If it does infiltrate, the necrosis won't be as bad, right? And it's going to be more gradual buildup of blood sugar levels, where it's going to be able to be sustained a lot longer as well. So they'll be opting for that, and there we have 5% dextrose, which doesn't do much for diabetic patients, but they'll use that to mix in other medications. Right? So the medic will typically call out what size bag they need, and then we just go ahead and set it up for them. Now, as far as the tubing, okay, we call them drip sets, or administration sets. And there are 2 different styles. So we have macro drip and micro drip. Right? With macro drip tubing, it's going to be set to 10 or 15 GTT per ml, which means drops per milliliter. GTT, I keep forgetting what it is. It's some German word. It means drops. It's irrelevant for you. Okay, but basically it's drops per ml. So it doesn't measure flow rate, it measures flow volume. Okay, so it's essentially setting how many drops it takes to create 1 milliliter of fluid. Okay, so with macro drip, it's going to be larger, fatter droplets to make 1 milliliter of fluid. Whereas micro drip, it takes 60 little itty tiny drops to make 1 ml of fluid. Now, as far as the actual packaging itself, you're going to see a number here, okay, that'll let you know what the actual drip rate is. So because this says 10, what type of drip set is it?
Macro.
It's macro. Okay, here we have 60, indicating it's micro. Now, if we don't have the packaging available because someone threw it away, we can simply look at the drip chamber itself. So the micro drip tubing is going to have a little itty bitty tiny needle inside of that drip chamber. Okay, and with that little tiny needle is where we get the little tiny droplets. The macro drip does not have that tiny needle, so we're going to have bigger, fatter droplets. All right, stupid little trick that I use to identify the difference. Right, micro drip has a tiny needle, and if you were to flip that around, it looks like the needle with a little tiny drop coming out of it. All right, whereas the macro drip, to me, a lowercase a kind of looks like a droplet, sort of, if you squint the right way. All right, but it's going to be a larger, fatter droplet compared to that little tiny dot on top of the eye. Okay, so the medic will pretty much call it what they need. Hey, set me up micro drip or macro drip. Grab 10 or 15, doesn't matter. Okay, but this is for fluid replacement in the case of a bolus. This would be for med administration through an IV. So they can more accurately control the dosage here. Now, as far as the actual tubing itself, right? There's obviously two ends. Okay, so we have this part right here, okay, which is going to be the piercing spike. This has to be sterile. Has to be what?
Sterile.
So can I do this?
No.
No, because we're not what?
Sterile.
Right. Okay, and the reason why this has to be sterile is it goes into the bag, which means the fluid goes into the
Body.
patient. Okay, so we want to make sure that stays nice and sterile. So we'll leave the cap on. We have our drip chamber, which is going to be a soft, flexible, kind of rubbery material. Okay, and then we have the actual tubing itself that goes all the way down. This part is where it attaches to the IV catheter. Okay, and it follows our standard thread pitch. So lefty loosey,
Righty-tighty.
right, there you go. Right, righty tighty to go and secure it, right, and attach it there. That end also has to be sterile. Oops. We're going to have other administration ports, so the medic can go ahead and administer medications through different ways through the tube instead of through the bag itself. So if they're giving saline, but like, oh crap, we have to give a certain drug through the IV, they can just give it through this part instead. Or one that's going to be a little bit higher up. Actually, this one doesn't have it. There may be another port higher up. This here is a little slide valve, or a little slide lock rather. So it just pinches it off, right? So if you need to shut down super quick, you just slide that and pinches off the tubing. And we have our roller valve. Okay, this is what I use to determine the flow rate coming out of this thing here. Okay, so it's going to be a wheel that's basically on a wedge, and as I roll it down, it's going to pinch off the tubing, right? And the further down I go, the more of a pinch it's going to have. Okay, so when it's locked, it's going to pinch off tubing, which will be all the way down. If it's all the way up, it's unblocked, and I can slide this wherever I want onto the tubing. All right? So that's what we're going to have there. As far as the tourniquet, so it's going to be these things here. This is a really, really short one because it's broken, right? But they're going to be venous tourniquets. So they stop venous blood flow, but not arterial blood flow. Okay, and when the medic puts this thing on, they're actually palpating for veins. They're not looking for them. They're what?
Palpating.
Palpating. They go based off feel. Okay, because just because you can see the vein doesn't necessarily mean that it's the easiest one to get to. Okay, because we don't know exactly how deep it is. But if I can feel the vein, do we know it's close to the surface?
Yes.
Yeah. All right, and they're generally going to always start distal, work their way proximal. Okay, and the reason why they go distal to proximal has to do with where blood is going when it's going through a vein. Veins take blood where?
Back to the heart.
Back to the heart. Okay, so that blood's going to start working its way up, right? Proximal, right? Working its way back in this way. So if I were to blow a vein here, could I start up here?
No.
Yes.
Oh.
Right? Because, okay, down here it's not going to have any effect because I'm working its way back up the line. But if I were to start a IV here and blow it, can I start one in the hand?
No.
No, because that blood's going to start working its way up and then start coming out of that hole. Okay, so they always want to go distal to proximal. Right, now as far as patients just needing IV access, just to have an IV, they'll go for the hand usually. But if they need fluid replacement, they're going to go for the AC, or the antecubital fossa. Larger vein is going to be right down here. Pretty much right where we would put our stethoscope to get a blood pressure. Okay, so they may want to get a line there. And any other place they can get vascular access, they'll try to get an IV. Now, for those patients who are IV drug abusers, okay, what kind of marks are we going to see around their body?
Track marks.
Track marks that they may use what to cover up?
Tattoos.
Tattoos. Okay, and if a medic were to see a patient who's an IV drug abuser with tattoos on the forearm, right, they may not be able to go here because it's going to be so heavily damaged through all the previous injections, they can't get through the scar tissue and get suitable veins. Right, so they may have to start going to different places. All right, and the IV drug abusers will start doing the same thing. All right, I had a patient who abused the crap out of meth and shot up everywhere. Medic couldn't get any lines whatsoever. The only place he could get a line was in the patient's foot. It's the only place the patient wasn't shooting up, and they had to use a little itty bitty tiny kid-sized needle to get vascular access, and that's all they could get. Right, so we have to try to look for other things. Sometimes they'll go for the jugulars too, right, if they really need to get some big lines going through. Right, but just IV access, get it wherever we can. Now, as far as the IV catheter, okay, pull one out right here. Figure out this shit. There we go. So, as far as the catheters, okay, there is a bunch of different sizes, and it's all going to be based on the diameter of the catheter, not necessarily the needle itself. Okay. Now, the catheters are based on gauge. So, the smaller the number, the bigger the needle. So here we have an 18 gauge, which would be larger than the 20 gauge. Okay, now on the catheter itself, right, and the needle and whatnot, okay, the needle end is going to be sticking out so we can actually penetrate the skin and get into the blood vessel, whereas the catheter is what stays in the patient. And it's a flexible piece of plastic, right, that's going to stay inside the blood vessel. And then this part is where we have our threaded attachments, okay, where we can put on things like the IV line itself. So once this is in the patient, we can go and thread that on, right tighty, right, and then fluid will start coming out into the patient's bloodstream. There are other devices we can use to use basically as a quick attach for the IV. That being these locks. So with the lock, it's pretty much going to go ahead and thread onto the catheter. This part will close itself up, and we can go ahead and attach our catheter. What's that? Right, we can go and attach the IV to this, right, and get vascular access. And if I have to move the patient, all I do is unscrew this, keep it sterile. This will be attached to the patient, move them, do what we got to do, and then I just go and reconnect it, and then they're getting their fluids again.
Is there like a standard gauge for most IV drips, or is it good?
It's usually 18 to 20 for adults, and then larger numbers, therefore smaller needles for kids. Yeah. Now on the IV itself, there's a little chamber down here, just distal to the catheter part. That's called the flash chamber. So once the medic gets into the vein, that's going to start filling with blood to indicate that they're in a vein. And then what they're going to do is they're going to advance the catheter while withdrawing the needle, just like this. Okay. Now, if they were to advance the needle, right, and withdraw the catheter, so do opposite what they're supposed to, that can lead to a complication we'll get to in a bit. So once they have the catheter in the patient, okay, and they pass it all the way through, they'll secure it and then get access going through. Now, of course, there will be blood, so obviously you do want to be wearing gloves. So that way we don't get any type of bloodborne disease. Some complications, one of them being infiltration. So this is why they don't really give D50 anymore, because that catheter and needle can go through the vein all the way through and start leaking stuff into tissue around the area. Right? And certain medications are going to be necrotic to tissue, like D50. Right? So that very, very syrupy fluid is going to start sucking up all the fluid from surrounding cells, right, and then kill tissue that way. Right? Now, usually if it's something like saline, it's not going to cause any major problems besides just some swelling in the area and a bit of burning and uncomfortable feeling, but that's about it. If that happens, then we just take out the catheter, right? Just put a Band-Aid on and that's it. But other medications, again, are going to be a little bit more serious. Phlebitis is going to be inflammation in the blood vessels, and we get some local inflammation from the actual injection site itself. Okay, so a little bit of redness, a little bit of swelling wherever they get stabbed. But if it's not clean, then it might start to infect inside of the patient. Right, and these are all relatively local, whereas systemic issues, one of them being a catheter shear. Okay, so that's what happens if they advance the needle but withdraw the catheter. What they're supposed to do is advance the catheter, withdraw the needle. Okay, so by pushing the needle forward, they can basically cut off a piece of the catheter, and now it's going to be floating through the patient's bloodstream. So now we got a little piece of plastic that's floating around the patient's bloodstream through their veins, and then gets stuck in the lung, causing a pulmonary embolism. And way back when we first talked about it, we said it was a blood clot, air bubble, or other foreign body that gets stuck in the patient's lung. This is that other foreign body. Okay, so if you've got a medic who just started an IV, and then a couple minutes later, the patient goes, oh, and starts having a sharp pinpoint chest pain, right? Good ton of volume, crappy O2 sats, we have to suspect the possibility of catheter shear. All right, so piece of plastic, can't really do anything about it besides remove it surgically. So we just got to haul ass to the hospital really quick. All right, another issue we have to worry about is circulatory overload, which is exactly what it sounds like. You overload which system? Circulatory system. And you do that by putting in too much fluid. Okay, now a regular healthy adult patient is able to compensate for a little extra fluid. Right? If I were to put a whole 1 liter bag in one of you guys right now, you'd be fine. You would just have to do what?
Run.
Pee it
Oh,
out.
pee.
Yeah. Okay, because your body's got all the extra fluid. Kitty's like, hey, you've got too much water in here. Let's piss it out. Okay, but certain patients can't really do that, such as those with kidney problems. Okay, so patients who are on dialysis, right? They really don't urinate. Okay, they can't control all the extra fluid. So all that fluid is going to start to go through different parts of the body and might start backing up into their what? Into their lungs, and now the patient's got pulmonary edema. Okay, patients with liver problems, same thing, right? They can't filter all the extra fluids, so it's going to start backing up different parts of the body. Okay, patients with like right-sided CHF, okay, they can't really filter all the extra stuff. They're going to have fluid back up as it is, and now I'm adding even more fluid, all right, complicating their issues. So the medic may have to determine, okay, this patient's got a history of renal failure, right? The kidneys are all jacked up. I want to give them just little bitty tiny amounts of fluid, right, but not give them too much. Okay, pediatric patients, it's the same thing. Right, since kids are small, right, they can only tolerate so much extra fluid. So we'll talk about what the medic has to do for kids in the next slide. Right, then we have the vasovagal reactions. So this is when your patient suffers a syncopal episode, right, from seeing blood and or needles. So what kind of shock is that? Psychogenic. Okay, and it's because of these episodes that a medic is not going to start a line on a patient who is standing up. Because if they stand up and they pass out, they're not going to go down and have a possible spinal injury. All right, but those are the easy patients because they don't complain, at least while they're getting stuck. All right, so we just have to look out for that. As far as pediatrics, we'll use a special type of IV tubing called a Volutrol. And it's going to have two different drip chambers. So this one is going to be graduated, so it's going to be having markings going all the way through. And then we have our other drip chamber that we're going to use to actually pull fluid from. So the medic has to determine, based on their protocol, what's the max amount of fluid they can give on the kid based off of weight. So let's say, for example, okay, a medic's protocol says they can give 10 milliliters of fluid per kilogram of weight. Okay, so every kilogram the kid weighs, they can give a maximum of 10 mLs of fluid. Let's say you have a 15 kilogram kid. What's the max amount of fluid they can give?
50.
Oh,
15.
See, you guys suck at math. That's why we don't do med math as BLS. You screw it up all the time. Okay, but they'd have to basically multiply, right? Okay, kid weighs this much, multiply that number by 10, that's what I get. Now, obviously, that's just an example. It's all dependent on protocol. But they'd fill it up to 150, and then they use this to pretty much suck up from this chamber without actually tapping into the bag itself. All right, so as far as the tubing, it's pretty much the same. We're going to have the part that goes in, right? We have our slide lock, our roller valve, rather, slide lock, different administration sets, right? Piercing spike. Okay, so all that stuff is going to be pretty much the same. We just have two different chambers to look at, right? And then fill up that proper volume. Now with this, they also have smaller tubing because kids have smaller veins. We're also going to be using smaller catheters, but again, the larger the number, the smaller the needle. So for kids, we'll be using a 22 or 24 gauge, whereas adults may use an 18 or 20, or if they're being jerks, maybe even a 16. All right. So we'll go ahead and set the medic up for that stuff, and they'll give the fluids as needed. All right, when it comes to troubleshooting IV issues, sometimes there are problems. First off, check your administration set, so make sure it's actually turned on, that we actually have flow. Because it's one of the very common things, we forget to actually open it up. Check the height of the bag, because these are dependent on gravity. Okay, so the higher up the bag is, the more pressure it's going to generate, pushing more fluid into the patient. All right, that's why I always see it in movies. People are trying to hold it up as high as they can, all right, so they can start pumping as much fluid as they can to the patient. All right, if I have the bag below the patient, I'm now taking fluid from the patient, right, and then the bag starts to fill up with blood. And if that happens, no big deal. It's a patient's blood, so what do?
Raise it.
Put it back up. All right, so the bag starts turning red. Oh shit! Just pick it up, right, and just let it start flowing back into the patient. Check the type of catheter that's been used. Okay, so again, we want to make sure you're using the right size catheter for the right patient. If the catheter is too big, it can actually destroy that blood vessel. And if it's too small, it's not pushing enough fluid that the patient's going to need. All right, and check the tourniquet. Very common thing, right? Forget to pop the tourniquet off, so you have increased venous pressure, which means the blood will start backing up, even if I have the bag elevated. Right? It's like, what the hell? I got the bag elevated, still going up. Oh yeah, the sleeve went up. Pop it off, and then that blood should start going back down. Right? So, I'm going to go and show you guys how to set up a bag really quick. Really straightforward. All right, so once we have a fresh tubing, okay, we're going to go and pop the cap off, right? Leave this thing on. And again, this has to be what?
Sterile.
So can I do this?
No.
Because then what do I have to do?
Get it.
Start all over again. All right, as far as the bag, okay, the bag's going to have little things, little tabs that will pull off, right? And then very carefully, we have to take the piercing spike and pierce it into the bag without doing all this kind of stuff, because the outside of the bag is not going to be considered sterile. Okay, so you have to pretty much do it in one shot. Press nice and firm to puncture the seal, right? And then we go ahead and turn it upside down. Now, before we do that, you want to make sure that your roller valve is turned off, so it's all the way down. Once we're at the bag, and then I want to fill this up, right, until it's about 3/4 of the way full. Okay, so you just keep squeezing, and you go ahead and prime that chamber. Keeping that bag elevated, I'm now going to open this up, and I want to run it wide open so I can flush all of the air out of that tubing. Okay, so we'll keep on going up until it starts dripping out like that. And then I'll go and shut it down. Okay, once we do that, I'll take this portion and I'll give it to the medic so they can go and put it into the IV catheter. So it'll look a little something like this. So this one doesn't have the locking system, so it's kind of old, but it's just going to go in like so. That way, when it's in the patient, it's going to start shooting out just like that. All right, so that's going to be going into the patient's bloodstream. Now, if I have a larger catheter, right, it's going to go and start pumping out more fluid. I feel like Austin Powers doing this. We'll go and have it elevated, right, and then administrate fluid that way. If we have to swap it out, then we just go ahead and basically start all over again. And the benefit to having one of those locks is that if I got to move the patient, okay, all we have to do is just simply detach it from this portion. This will stay on the patient, do what we got to do, and then we just go ahead and plug it back in. We go from there. We just have to be careful that we wipe this with alcohol first before I start plugging it back in. Okay, because if it doesn't have a cap, this can get dirty, and this has to be what at all times? Sterile, at least before we go and reattach. Okay. So that is going to be our IV setup. All right, and again, that whole setting up a line is pretty much going to be standard for us to do when it comes to starting up an IV for our patients. Now, little thing that I would do for my medics, one of them that I work with is like this kind of setup. I would set up what he called a little bouquet. So I would take a bag. We also have IV start kits, which is everything that we need. And Erica, do you mind passing one of those paper sets, please? All right, so we'll take our tubing set. I'd have one for each, so I'd have a micro drip and a macro drip. So I'll have this all set up with our tourniquet. I would just go ahead and tie all these things together. Just like that. So that way, if you needed to start a line, I just grab one of these. All right, hey, he's calling for a macro drip. Make sure I got the right size tubing. So this would be micro. That ain't gonna work. So I'll go flip for the one that says 10, grab it, and then hand it off, or just start setting everything up. All right, that way everything we need is right here. I don't have to go digging through stuff like that. And if we are working on an ALS ambulance, right, we'll have IV start equipment in the back. All right, so I would just stock these up. That way I just grab it, pull it, go right to work, instead of having to go through things piecemeal. Now, some medics that I work with later are like, I don't want that shit. Right? Other ones are like, oh, cool, that's actually pretty neat. So it just depends on who you work with and what they want. Again, going back to the whole like dependent, independent groups, things like that. So that is our ALS assist. And now we get to move on to geriatrics. Right? I know you guys have been waiting for this. Pretty exciting stuff, right?
It's almost like he's here.
I know.
Why?
What's up?
The IV bag, did they do that a lot? They're obviously going to do that a lot with dialysis, right?
Nope.
Oh, no?
Again, with the stuff, their kidneys aren't working, so they can't get rid of the extra fluid. right? So when they go to dialysis, they take out
Yeah.
fluid.
Through the whole system.
Dialysis patients, they have a tooth in their arm already.
Yeah.
Anyways.
Oh, for real.
Yeah, so they just need to have a needle that just goes right in. That's it. Alright, you'll see. So, we'll go ahead and get started with geriatrics. So, like I was saying the other night, okay, this is going to be a preview of our review lectures next week, okay, because pretty much everything we've talked about for medical emergencies pretty much going to pertain to geriatrics. A couple exceptions, okay, can a geriatric patient get croup?
Yeah, no.
No. What about epiglottitis?
No.
Because those are, again, childhood illnesses. Okay, between 6 months and 3 years of age, those are going to be your croup kids and epiglottitis patients. All right, and to tell the difference, Ramon, how can you tell the difference between croup and epiglottitis?
Croup will have a sad barking seal cough.
Sad barking seal?
Damn, press seals, you're like.
Jeez.
It's a barking seal.
Okay.
And then epiglottitis is gonna have excessive drooling.
Right. What does that barking seal cough sound like?
Oh.
Again, it sounds like a yelping dog.
Yeah.
All right. So, right, as far as croup and epiglottitis, again, they will have different things.
With epiglottitis, there's no suctioning, so do you just let them drool out?
Yeah.
And
Just let them drill out, keep them Fowlers, and that's it. All right. So, with other things, right, cardiovascular emergencies, kidney problems, liver problems, right, GI issues, okay, that's where we're going to be seeing a lot of in the geriatric patient. Okay, and again, these are our bread and butter daily, calls that we're going to run for these geriatric patients. Now, when it comes to definition of a geriatric, the standard definition is anyone over the age of 65. Okay, so generally speaking, if they're over the age of 65, they're considered geriatrics. And the only exception is when it comes to burns. When it comes to what?
Burns.
Where geriatrics is defined as anyone over the age of
55.
55. And whatever's moderate for us is
Critical.
critical for them. Okay, just the same as with kids, if they're under the age of
5.
whatever's moderate for us is critical for that. Now, when it comes to assessing our geriatric patients, okay, it kind of sounds messed up, but we treat them like a regular person until proven otherwise. Okay, so again, we don't assume that they all have dementia.
Are you
Okay, exactly. So don't assume that just because they're old, right, they don't know what's going on or they're senile or anything like that. Because most people nowadays, if they're old, are actually still pretty sharp and still pretty with it. Right? Thanks to modern medicine and whatnot, right? Grandpa's going to remember a lot longer compared to 70 years ago. Okay. As far as hard of hearing, again, not all geriatrics are going to be hard of hearing. Okay, so don't go yelling at the top of your lungs right off the bat. Okay, because they may be able to hear totally fine, or they may have hearing aids in place. Right? And if you come yelling at them, they're not going to be happy. Okay, and they're not all sedentary or immobile. Okay, so just because they're old, right, doesn't mean they're all like Grandpa Joe and Willy Wonka, right, where they just stay there until they win the golden ticket.
Jump up
Yes.
and do
Yeah. What the hell was that about?
Yeah. Social Security fraud. That's absolutely what it was. Right. So,
My whole family. Jeez.
so as far as that, again, we're not going to assume that all old people, right, just sit there and don't do anything. Again, a lot of the elderly are still pretty active. Okay. So, like I said, we treat them like a regular person until proven otherwise.
What proves otherwise?
When we do see things like dementia, hard of hearing, syndrome, mobile,
I thought
to see those signs.
Just do that with everyone.
Yeah, exactly. It's a good way to not get sick.
Treat people as intelligent people.
So, as far as communication with geriatrics, okay, we have to be patient with these patients. Okay, so we have to give them a little bit of extra time when they answer questions, and that's normal for geriatrics. Okay, we'll talk about why in just a little bit, right? But it's going to take Grandpa a little bit longer to answer the question than it would if you were to ask somebody else a little bit younger. Okay, you want to go and speak slowly, clearly, and distinctly, and get down to their level as well. Okay, because if you are towering over Grandma, is she going to feel comfortable? No. Okay, but getting down to their level, just like with kids, going to make that patient a little bit more at ease, right? And speaking slowly and distinctly, again, gives them time to understand and process whatever it is that you're saying. So with geriatrics, obviously we're going to see things that we're not going to see in younger patients. Okay, so certain types of infections like pneumonia, right, are more common. Blood clots are more common in geriatrics. Hip fractures, more common in geriatrics. All right, because with age comes an increase in the risk of those factors. All right, things like osteoporosis, okay, which will cause more brittle bones, where they can get what kind of fracture without trauma?
A mid.
Oh, no, I know.
Yeah, you should know it, sir, since we talked about it yesterday.
I got you.
Yeah. In here somewhere.
I remember, it's like the sponge, it's because their body weight, it's the compound fracture.
Not a compound fracture. 'Cause that
It's
breaks
the
the
body
skin.
weight, it's when it gives out.
Yeah.
Yeah.
Damn it.
What is it called?
I have it.
No.
I have it. Swear I have it. You want that? I have it literally right in my house. I'm looking at it. What's this?
That's my name. There we go, finally.
What's it called?
Pathologic. Okay, so patients can suffer pathologic fractures, which again is a fracture with no MOI. Okay, grandpa could just be walking down the street and hip goes out and that's it. Okay, so one question you want to ask is, did your pain come on before they fell or after they fell? Because if it came on before they fell and they remember, it's probably a pathologic fracture. If it came on after they fell, it's probably from the actual slip and fall. Okay, which again, osteoporosis still leads to easier fractured bones. Now when it comes to assessment, okay, for kids we have the assessment triangle, but for geriatrics we have the geriatric diamond.
Gems.
Yeah, use gems. All right. So we're going to be doing the geriatric assessment triangle diamond in more of the secondary assessment, whereas the assessment triangle is usually done where?
Primary.
In the primary. Okay. So as far as the GEMS and what it actually stands for, G stands for geriatric patient. So who do we use it on? Geriatrics. All right. Now once we confirm they are in fact an old person, okay, then we can move on to EMS, which is going to be environmental, medical, and social. So with the environmental assessment, it's not quite the same as environmental hazards, but it can be very similar. Okay, with environmental assessment, we're trying to see if the environment is suitable for the geriatric patient. Okay, so for example, do they have ramps instead of stairs? Right? Do they have one of those little stair lifts instead of having to walk up the stairs? Do they have handrails going down their hallways? Are their hallways wide enough for things like walkers and wheelchairs? Okay, so is the environment suitable for the geriatric? But we also want to look to see if it's the cause of the emergency. Is it too hot? Is it too cold? Because do geriatrics do well in extreme environments? No. Okay. Again, do we see things like rugs that may be tripped over, right? Unstable surfaces, things like that. So it's not the same as environmental hazards, but again, it kind of goes along with it. All right, we'll see if the environment may have possibly caused this injury or illness. For the medical assessment, it's pretty much just running through our sample NO-PQRST, okay, to see if that may provide clues as to what's going on. And do most geriatrics have extensive medical histories?
Yes.
Yeah. Okay, do they take a lot of medications?
Yes.
Yeah. Okay, so we got to think about that. Okay, what do they have in their history that can lead to certain complications? What medications have they taken to let me know what kind of issues they have? Things like that. And as far as the social assessment, okay, we're looking to see if this patient has any type of social network, not like Facebook or Twitter or anything like that. Exactly. Okay, are they social? All right, do they go out and socialize with other people, or do they have people coming in to check on them? Okay, so do they have a caretaker? Right, is family coming in, to see if they're doing okay? Right, things like that. All right, so these are things that we're assessing, again, usually in the secondary assessment to get an idea of what's going on and what we're going to be seeing with this patient. So, as far as the primary, again, doesn't change for anybody. Medical, trauma, pediatric, geriatric, okay, we run the exact same primary assessment. It only changes if they're unresponsive. But again, even then, we still do the same stuff, just slightly modified. As far as assessment of the geriatric, okay, what makes it difficult is we have to try to determine chronic problems versus acute problems. Acute, in this case, means
Short term.
sudden onset.
Oh, sudden onset.
Okay, again, you got to know the context. Okay, chronic being long-term, acute meaning sudden onset. Okay, so chronic problems, for example, may include, joint pain. Right? As some people get old, they may develop some joint pain, but not all people are going to develop joint pain. Okay, or we may have to say, okay, they have joint pain as usual, but why is it hurting more now than it hurts usually?
Repeat the definition of chronic.
Chronic is long-term. All right, acute is short-term or sudden onset. Okay, so we have to ask them, okay, how is it different today than it usually is? All right, and they'll tell you, oh, my hip is just really killing me today, whereas normally it's just kind of sore and achy. All right, now we also have to try to figure out the baseline level of consciousness. If our patient has dementia, are they altered?
Yes.
Do we treat them as they're altered?
Yes.
No. Okay, if they have dementia, yes, technically they're altered, but we're not going to treat them like an altered patient. which means I don't have to give them high flow 2, do a whole neurological workup, run through AEIU tips, just because they have dementia. What I do have to do, though, if they have it, is determine if they're more altered than usual. Okay, so we got to figure out their baseline. And how would I know their baseline?
Ask family.
Ask somebody who knows the patient. Okay, hey, is your dad normally like this? Yeah, my dad is pretty much like this. He has dementia. Oh, okay, cool. All right, so then we don't have to worry about, getting on oxygen, running stroke assessments, doing that kind of stuff. That's how they normally are. Or if they go, no, my dad normally knows his name. He knows where he's at. He just doesn't know the time. And now he doesn't know any of those things. Is that something we should be concerned about?
Yeah.
Yeah, because now he is technically altered, right? And we're going to treat him like an altered patient. Okay, so we have to figure out what's normal, right? And figure out if it's going to vary off the baseline. Right, and it gets really confusing if you're going to be doing IFT calls, because I got a call one time for an ALOC patient at the Alzheimer's unit. Go figure. Okay, so we got to go, okay, what's different about them today? Oh, I think he's having a stroke. Yeah, that's altered. All right, and we just go from there. Okay, but we got to figure out what's baseline and how they're different from that as normal. Okay, so again, use somebody who knows the patient and ask them, is this normal for them or what? Okay, when it comes to medications, again, geriatrics take a lot of medications. On average, it's 4 or more medications. Okay, so on average, the geriatric patient takes 4 or more medications. Could the geriatric patient have multiple doctors?
Yes.
Yeah, considering they'll have multiple medical conditions. Okay, so they could have fairly extensive medical histories, therefore requiring to go to a few different doctors, which are going to prescribe different medications. Unfortunately, the doctors don't always communicate or look over the patient's records to see what medications they're on already. So you can have Dr. A prescribe one medication and Dr. B prescribe the same medication, therefore causing a patient to overdose. Well, maybe not die right away, but overdose. Or Dr. A gives one medication, Dr. B gives another medication where they conflict, and can that cause complications? Yes. Okay, so with geriatrics, it's really important that we gather either a list of the medications or the medications themselves to take to the hospital. Because that may be why they're having problems. They're taking conflicting medications or they're overdosing on certain medications. Okay, we also want to ask the geriatric patient if they are compliant with their medications. So are they actually taking it as prescribed? Can geriatrics be stubborn?
Yes.
Absolutely. Okay, so we want to know if they're taking their meds as prescribed, and also have there been any recent changes to their dose? Okay, which includes starting or stopping medications. Okay, so any recent changes to doses? Have they started new medications? Have they stopped old medications? And unfortunately, when it comes to things like that, it's just trial and error. The doctor says, all right, take this medication at this dose and give me a call in 2 weeks and see what happens. Right? And they'll be like, oh, doc, it's not working. Okay, increase the dosage. Oh, crap, it's working too well. All right, decrease the dosage. Right? And just kind of fine tune it from there. Or, oh, this medication at this dose is not interacting with this medication at that dose. Let's try to see if there's a substitute. Right? And try to swap it out. Okay, so that was happening to one of my friend's grandpas. He was kind of go back and forth with all these different medications that were unfortunately going after his liver. Right, so his liver wasn't, or kidneys rather, weren't able to filter out stuff. So he actually started becoming hyponatremic, which means he had low sodium. And for the life of him, he just could not get enough sodium to be at normal levels. So they're having to try all these different medications and whatnot. And with that, because he has electrolyte imbalances, part of AEIU tips, what do you think was going on with him? Altered. Yeah, right. But his grandpa was having ALS because his sodium levels were too low. Right, because they're changing all these different medications, they're like, oh shit, that didn't work. Dial it back, let's try something else. All right, so we just have to look out for that kind of stuff and ask those questions. All right, look for the list, ask anyone else. We already talked about beta blockers. So those are medications that will not allow the heart rate to speed up. Okay, so beta blockers do not allow the heart rate to speed up. And those are usually given for patients who are hypertensive, right? Because we want to try to lower the heart rate by slowing down the heart rate, or lower the blood pressure by slowing down the heart rate. All right, but we also need that heart rate to increase in cases of trauma, since that's how we compensate. So if you have a geriatric patient who's got a heart rate of, let's say, 52, and they just crashed the car into a tree, should he be concerned?
Yes.
Yes. Okay, because this patient's bradycardic, they just suffered trauma, they might have bleeding on the inside that they cannot compensate for due to bradycardia. Okay, and again, some places that's automatic trauma criteria right there. We take them right to a trauma center because they're on those medications. Okay, so we have to think about that in assessment. They'll be like, oh, cool, he's got a slow heart rate, he's healthy. It's not always going to be the case. So when it comes to difficulties and complications, not all geriatrics want to go to the hospital. Okay, not all geriatric patients want to go to the hospital. And the reason why they don't want to go to the hospital is because they think they're going there to die. Okay, so they may intentionally downplay their signs and symptoms. Right? Classic example is an old man who's having crushing substernal chest pain and clear-cut presentation of an AMI going, it's just indigestion, that's all it is. Right? Where they're going to go and downplay it so they don't need to go to the hospital. Okay, but clearly you need to run your assessment and be like, no, dude, you got hypertension, you got all this extensive medical history, we just patched you up and you're showing a STEMI. Let's go. Right? Obviously we can't force them to go, but we want to try to go as much as we possibly can. Okay? As far as conditions, right, they may present differently because their nerves are not as sensitive as they were when they were younger. So they just feel pain differently. That's why for a silent MI, it's a patient who's a female diabetic and elderly. Okay? Because old people just don't feel as much pain as we do because their nerves are not as sensitive. Okay? So the old diabetic lady is like the perfect storm for a silent MI, but any diabetic patient, right, can have it. Geriatric patients are obviously at higher risk of an AMI just because they're old. Right? So we got to worry about that kind of stuff. All right? Don't worry about writing this down, but these are a lot of common things we're going to see with geriatrics: dizziness, falls, right? Respiratory issues, certain infections, things like that. So these are calls that we're going to be running on the daily for geriatrics. Now, as far as things we got to be on the lookout for geriatrics, okay, some things happen just because we're old, and it's just because we're old. Okay, other things, though, are directly caused by illness. Okay, and we can't assume that, oh, they have, osteoporosis just because they're old. It doesn't work that way. Okay, but grandpa may take a little bit longer to answer questions, but still be ANO times 3. And that's fine, because that stuff happens when we're older. But straight up ALOC, dementia, Alzheimer's is not normal with getting old. Okay, so again, we have to try to figure out, okay, what is normal for a geriatric patient? Right, what do I expect to see just because they're old? Or what's going on because they have some type of medical problem? Again, hip pain. Is hip pain normal just because you're old?
Yes.
Yep.
No, not really. Okay, some joint stiffness maybe, right? But joint pain, not necessarily.
Oh.
Okay, again, taking a little bit longer to answer questions, that's fine. Just happens when you get old. But being totally altered, that's not normal. Okay, so again, it makes it a little difficult. What am I going to see just because they're old versus what do they see because they have some type of medical problem? All right, so when it comes to the respiratory issues, right, geriatrics are prone to a lot of respiratory problems. Okay, especially pneumonia. All right, do geriatrics have strong immune systems?
No.
No. Okay, so they're very likely to start getting infections, especially respiratory. Now with kids, right, pneumonia is the #1 medical killer of pediatric patients. When it comes to geriatrics, okay, it's the #1 killer from infection in geriatric patients. So if an old person were to die from an infection, it's probably going to be pneumonia. And in geriatrics, can pneumonia go septic? Yeah, very easily. Okay, since patients may end up dying from septic shock, chiefly caused by pneumonia. Okay, they're also more likely to develop a pulmonary embolism. And Axel, what is that mnemonically used for the causes of blood clots that can lead to a pulmonary embolism? That's it.
Isn't it AEI?
Nope.
Bad pearls.
Bad pearls. What does that stand for?
Birth control, AFib, deep vein thrombosis, pneumonia, P's. Prolonged periods of non-movement. So,
I'll buy that.
P. RLS, right?
Daisy, what's P?
You sorry? You said he?
Yeah, and bad pearls. So So we got birth control, AFib, DVT. You said it, just not the way it's stated. It's supposed to be stated. Right, prolonged immobilization. Finish it up.
Recent surgery.
Uh-huh.
Long bone fracture and
Okay.
sickle cell anemia.
Right. Okay. So we got birth control. Now, are geriatrics going to be on birth control?
Probably not.
Hopefully not. Right. So we don't have to worry about that. Okay. With AFib, right? Can a geriatric patient have AFib?
Yeah.
And that's pretty common. Okay. DVTs, right? Which can happen due to prolonged immobilization, which can happen because of recent surgery that may occur because of long bone fractures. Okay. And those are very common in geriatrics. Hip fractures are considered long bone fractures. Okay. And when they require surgery for a hip fracture.
Yes.
Yes. Okay. And are they going to be walking around right after their hip surgery? No, which leads to prolonged mobilization, right? And then can cause a deep vein thrombosis. Okay, so that little chunk right there in the middle is pretty common in geriatrics. As far as sickle cell anemia, that's all genetic based. Okay, so with bad pearls, right, it's a big, big problem in geriatrics, right? But of course, anybody can get blood clots. All right. When it comes to other issues like COPD, chronic obstructive pulmonary disease, okay, we see a lot more in geriatrics because they've had the
Longest
time,
time.
okay, to screw up their lungs.
Old smokers.
Exactly. Okay, so they've had the decades and decades and decades and decades of toxic gas inhalation, right, or repeated episodes of bronchitis, okay, which leads to destruction of cilia to then cause COPD. All right, so we're not likely to see it, COPD in a 25-year-old male patient. Okay, we're going to see it in the 65-year-old male patients, right, especially with a history of smoking or inhalation of toxic chemicals. When it comes to the heart, okay, the heart is a what?
Muscle.
It's a muscle. And the more you use a muscle, what happens to it? Well, before it
Bigger,
gets tired,
yes.
it gets
Bigger.
bigger. Okay, so as we get older, our heart gets bigger. Not like the Grinch, where it's 3 times the size. Okay, and enlarged hearts is actually not good for us. Okay, now our heart is going to expand a little bit outward, but again, we only have so much space inside of our chest, which means instead of going out, that heart is now growing
Down.
inward.
Oh.
Okay, so instead of growing out, it grows in.
So it closes this stuff inside.
Right. So here we have a healthy heart. Right. Here we have a heart with hypertrophy. Okay, where the walls of the ventricles start getting thicker. With the thicker ventricular walls, we have smaller ventricular spaces, decreasing stroke volume. Because again, stroke volume is the amount of blood that comes out of the heart per
Contraction.
contraction.
Can't you just make more space in the chest?
Well, then you have to cut out lungs, sir, and we kind of need those.
Why does their bodies like, okay, I'm done growing?
Yeah.
Because
Yeah.
dumb.
They're
You
muscles.
can't get taller than how can you get bigger? That's not fair.
It's muscles.
Dumb.
It's all muscle. The heart's making gains. That's all it's doing.
You gotta respect that.
Yeah.
Yeah.
You know what?
Yeah.
Never
Good on you, Art.
I can get
You got
behind
more
that.
discipline than me.
Right. Okay. So, right, as the heart's getting bigger, okay, we actually start seeing more complications because the spaces get smaller. Right. Now notice the atria don't really get that much larger compared to the ventricles because the atria don't have to move blood super far. It just goes right down. But the ventricles, right, they got to push blood out a lot further. The left ventricle out to the rest of the body, the right ventricle out to the lungs. Okay, so they got to pump a lot harder, hence why they start getting a lot larger. Now, what ends up happening is that it's going to get to a point where it gets to diminishing returns, right? In order to compensate for decreased stroke volume, what happens to the heart rate?
Higher.
It goes up, which makes the heart work even,
Harder.
which makes it get even,
Bigger.
which kills your patient even.
Faster.
Right.
Bro.
Okay, where you get to a point where, again, the heart just shuts down, and then you die.
Is that how you could just die normally? Like,
Usually that's what happens. When you die of old age, usually the heart or some other important body part just shuts off.
Damn.
people
Right.
live for like 110 too.
Kill them.
Because they have usually healthier hearts, right? Now this is also pretty common in powerlifters, right? Powerlifters.
Yeah.
Right? Big old people that like lifting heavy things just because to lift heavy things, right? They usually die pretty young because of these enlarged hearts.
I thought it's because
Yeah.
they ate bad.
You never heard of like where they weigh their heart? I think there's someone who with like a 15-pound heart, like they took it out of the chest and like they
Yeah.
weighed it.
Yeah.
It's insane.
Yeah, usually that's what kills them, right? People who tend to do a lot of cardio too. Sometimes this will happen for some of them.
See, cardio bad for you. It's not cardio.
So, as far as AFib, okay, that's when we have atrial fibrillation, and this is where we have dysfunction of the SA node. Okay, so the SA node is not putting out consistent, regular beats like it should. Okay, so it starts kind of just sending out these erratic signals. That's why, right, we have an erratic baseline here instead of that nice, consistent flat, whoop, and then big spike. It's all over the place. Now, because the SA node is sending out irregular signals, the patient's going to have what kind of heart rate? Irregular.
Oh.
So you do a full minute.
Well, if we're checking for vitals, yes. But in COBS, I'm not checking for a full minute. In COBS, I'm just going, oh yeah, it's irregular, right? And that's it. And then we'll actually count later on.
So what's the difference between AFib and VFib?
A lot. VFib, they're dead. AFib, they're not, right? Because again, VFib, the whole heart is just doing this, whereas AFib is just the upper chambers of the heart. Okay? So what can happen is we have irregular heart rates, and that's what we see on this rhythm strip here. So it's going to be as corny as it sounds. Beat, 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 beat. Right? That's what we're going to feel, right, as we're actually palpating a radial pulse. Okay, so it's not going to be consistent, and that's why we check for the full minute. Now with AFib, can that lead to complications?
Yes.
Yeah, they can get a blood clot that gets stuck in their lungs, and we call that that's why it's the A in
Bad
bad pearls, right? Atrial fibrillation. Oh my God.
That was cool.
Wow. Now, if that blood clot starts on the right side, it leads to a PE. But if it starts on the left side, where can that clot go, potentially? To the brain, causing
Stroke.
what kind of stroke?
Ischemic.
Ischemic stroke. Okay, and then that goes on there. Okay, so if you got a patient who's showing stroke-like signs or symptoms, and you check their pulse and it's irregular, do we have a pretty good idea of what caused that stroke?
Yes.
Yeah. Okay. Just if I have a patient who suffers a syncopal episode with an irregular heart rate, do I have an idea of what caused syncope? Yeah. Yeah. Okay. With AFib, right, there could be a period where there's no ventricular contractions for a while to where blood doesn't get up to the brain. Right? That's why, again, syncope is just interruption of blood flow to the brain. And we can get that with irregular pulses.
They have AFib for a while with no complications.
Yep. Yeah, and AFib is usually generalized as controlled or uncontrolled. If it's controlled, they usually say it's stable and a heart rate less than 100. If it's uncontrolled, then it's unstable and it's over 100 beats per minute. Right, and that's where we start getting those complications. So usually you'll have patients who are tachycardic with an irregular pulse and show other signs or symptoms.
Would most geriatric, when they get to this point, would they not go and try and get a pacemaker to level out their heart?
They would. Yeah, so if the doctor says, hey, you've got AFib, I suggest you get a pacemaker to reduce your risk of having strokes and blood clots in your lung and other cardiac issues, I recommend you get that done. Right, and that's what they'll be putting it in for. As far as our silent MIs, again, those are our old diabetic ladies who are just feeling what?
Tired.
Right, okay, so we have to worry about the possibility of that silent MI. And again, if you have that, wouldn't it be a bad idea to just be like, hey, let's throw on an EKG just to be safe. So that way we don't, have to worry about catching STEMIs or anything like that. All right, so more common in those patients. Now, as far as heart failure, again, as the heart gets bigger, ventricles get smaller, okay, which can lead to heart failure and therefore blood backing up. Okay, is CHF a disease? No, it's a syndrome, right, where it's a collection of signs and symptoms. Okay, and sometimes patients get it just as time goes on and their ventricles get smaller. Okay, and obviously we can tell which side of the heart is more acutely affected based on backup of blood flow. So if I've got a patient who's got jugular vein distension and pedal edema, what am I suspecting?
Right-sided heart.
All right, right-sided heart problems. If they got pulmonary edema, what am I suspecting?
Left-sided.
Left-sided. Okay, because it just has to do with where that blood is backing up to.
So, for a blood clot, why is it that it has to go from the right side, from the inferior vena cava or the superior vena cava to do a pulmonary embolism, but on the left side it makes a pulmonary edema? On the right side, a blood clot will happen.
They're totally different things that you're talking about right now.
I've just been really confused on those two things, though. That was...
Yeah, because you're talking about blood clots for the right side, but you're talking about backup from the left side. Okay, so again, it's all about that box heart. Okay, with a blood clot, it's not backup. It's just going with the regular blood flow, and because the right side of the heart pushes blood to their lungs, that blood clot just gets stuck in the lung, right? Whereas if they have backup on the left side of the heart or the right side, doesn't matter. Blood goes from the ventricles back up to the atria, back into the vessels that feed the atria. So in the case of a right-sided backup, it goes back up to the jugular veins, back down to the feet.
Okay.
Left-sided, that blood backs up from the left atria into the pulmonary veins, into the lungs.
All right.
Okay?
Yeah.
With the blood clot, it goes with blood flow. With backup, it's backing up.
Okay.
Okay? So that's why, again, I told you way back on the second lecture, know your box heart. Right? Because it tells you exactly what's happening inside, where blood's going. And to understand CHF, you turn those arrows backwards. Right? And then it just traces blood flow back. Right? But with a blood clot, because there's no damage to the ventricles with just a regular blood clot, it's going through the heart, right? It's just going to go with regular blood. All right? So here we have an example of pitting edema, right, where we see that pit. And the deeper and longer that pit stays, the worse off the swelling actually is. Right? And again, we can see that blood coming down from the body because we have right-sided heart problems. All right? So, when it comes to strokes, are geriatrics at high risk of strokes?
Yes.
Yes. Okay, due to a variety of different reasons. Blood clots, right? Atherosclerosis, okay, which is plaque buildup inside of their blood vessels. Now, as far as the difference in between a thrombus and an embolism, Erica, what's the difference?
Embolism starts elsewhere in the body, and thrombolism stays where it is.
All right, a thrombus, right, stays where it's at. Okay, whereas the embolism gets evicted and it moves around to different parts of the body. Okay, so that's where we get our ischemic strokes. And in the field, can I tell the difference between an embolism and a thrombus?
No.
No. Okay, we try to look at history, but at the end of the day, we have a blockage in the brain. All right. With our hemorrhagic strokes, they tend to complain of, but it tends to be their last. Okay, so as they have development and then rupture of a cerebral aneurysm, okay, they start spilling blood into the brain. And do blood cells and brain cells play well together?
No.
No. Okay, so again, the brain cells flat out die. Right, and then causing a lot of issues. Now, as far as the primary risk factor for patients who are having hemorrhagic strokes, Darj, what's the primary risk factor?
Repeat the question again.
What is the primary risk factor for a patient to have a hemorrhagic stroke?
Primary risk factor would be falling.
Because it's traumatic. Strokes are non-traumatic. No. Primary risk factor for a hemorrhagic stroke.
Oh, the aneurysm, right?
Well, that's what it is when it ruptures, but why is that going to happen?
Maybe the artery or the blood vessel was overworked. I don't know, gave out. I don't know.
George?
Blood pressure, right?
Yes. Trying to ask my
Oh.
students. Yeah, high blood pressure, right? Hypertension.
Yeah.
Okay. Oh yeah, you even had a quiz question on it. That's right. Yeah.
Bigger until they go.
Okay. Hypertension, right, is the number one risk factor for hemorrhagic strokes.
Oh.
Do old people have hypertension a lot?
Yeah.
Yes. Okay. So that's why again we tend to see it right in geriatrics, but can I also see hemorrhagic strokes in younger patients?
Yes.
Yeah. And same thing. They're going to get it because they are probably going to have hypertension. Okay. And things like drugs can cause hypertension. Okay. So like we said, those stimulants, the sympathomimetics, right, they can cause increased blood pressure and then rupture of blood vessel in the brain, just like I told you about that one patient that I used to transport. Right? Partier, did a bunch of coke, and then burst a blood vessel in his brain, and then can't use half his body anymore. Okay? So we do have to be worried about that in those patients. Now, as far as a TIA, looks like a stroke, sounds like a stroke, but is it a stroke?
No.
No, right? Because the body's going to get rid of that blood clot on its own within 24 hours. Okay? But are we going to sit there for a whole day next to the patient and be like, you feeling any better yet? Feeling any better yet?
No.
No. Right? We just simply go, ah, crap, we think they're having a stroke. Let's go. The hospital's going to do the same thing. Ah, crap, I think they're having a stroke. Let's take them to go get some thrombolytics. Okay? So we are going to be seeing those in geriatrics as well. All right? So when it comes to neurological issues, okay, as we get older, we are going to start losing some neurons, which are just get nerve cells and connections between them. Somewhere between 5 to 50%. All right, now 5% is typically normal on the lower end there. All right, I mean, we're not going to see a whole lot of deficiencies for a patient who loses that little. All right, again, taking a little bit longer to answer questions, but that's about it. Okay, but when you get to 50% loss of neurons, that's where you start getting to that severe debilitating Alzheimer's where they can't do anything for themselves.
Is there any area of the brain that's like predisposed to lose more, or is it kind of just random?
I have no idea.
You start off with less than other people?
What's up?
Can you start off with less neurons than other people?
Yeah, probably.
I'm nervous of that number.
Okay.
That makes sense.
So, as far as the loss of neurons, again, it's a sliding scale, so it just depends. The more you lose, the worse off you're going to be. Okay, senses, right, are dependent upon neurons. Okay, so those senses may also start to diminish. Okay, that's why people can't see very well, they can't hear very well, right? Their taste is kind of diminished, right? Sensation. All right. As far as speaking, again, it takes a little bit longer for them to process and therefore think about what they have to say. Okay, and when it comes to the brain, as we get older, our brain shrinks. Okay, so as we get older, our brain gets smaller.
When
It
is
just happens.
when is the brain at its max
Potential.
potential?
right?
So they say aging starts at 30. So I have 2 weeks to enjoy it.
Right.
So, as far as that, yeah, they start saying you start going downhill after 30. So,
Can you?
I feel like I'm already going downhill.
Yeah.
Yeah.
I don't know. I think I was going down.
It's been a constant decline.
that's on
There's
average.
been no growth.
I mean, you go downhill from the second you come out. So,
That's true.
Technically.
but as far as that, yeah, that's when that all starts. So again, as we get older, brains start shrinking. Okay, so that's why it takes geriatrics a little bit longer to process information because their brains are just not as big. Okay, and that's why you have to be patient with these patients. Okay, so give them a couple seconds. Hey, what's your name? Bill. Okay, Bill, what's going on? My stomach hurts. Can we help you? Yeah, sure, that's fine. Okay, so we have to sit there and wait a little bit, right, as we're answering. But again, are all people, old people, going to be altered?
No.
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 Again, if it takes Grandpa a couple extra seconds to answer, well, that's just Grandpa.
Isn't the brain a muscle? So can't they make it bigger?
It's not a muscle. No.
Oh, it's not?
I thought it was a muscle.
No, it's not a muscle. It's a
Well,
collection of
That's
nerve
why
tissue.
I was told my it's like you don't
Brain
use it,
is
you lose
time.
it. That's why like you
Right.
old people are
You
dumb 'cause
can
they stop
increase
using
the amount of
their brain.
folds that are in your cerebral cortex, but you can't grow your brain. It's called cerebral edema, and that's a problem.
Would that mean contra injuries are probably more severe because it's a smaller thing instead of the same size container just bouncing around?
Yeah. Yeah, so it's going to be more light. It's going to be more of an issue because it can get more velocity as it moves in. But we also see a delayed onset of signs or symptoms because there's more room for it to swell before it actually becomes a problem.
Okay.
Right? So that brings me to the next point. Shannon, do you have a question?
Huh?
Do you have a question?
I was thinking about Kukanchaku.
Oh, okay. You know what it is?
Yeah.
What is it?
It's when your brain's shaking in that fluid, right?
What's the fluid called?
Intercranial fluid.
No. What's that fluid called? George?
Yeah.
Not
that.
CHF.
No? Oh.
What's that fluid inside of our head called?
Oh, no.
Surrounds the brain and spinal cord.
Intracranial fluid.
No.
Cerebral spinal.
Thank you.
Yeah.
Right, cerebral spinal fluid.
CSF.
Yes.
Not CHF.
Yeah, CHF is congestive heart
I was a little
failure.
worried there for a second.
Oh, I was very
He's
worried.
supposed to be the one going downhill, not us.
It's like very question common.
For some patients, it can be, yeah. Right. Usually, though, that's kind of an earlier sign of dementia. Right. Very, very early stages where they kind of have short-term memory loss. Now, with the shrinking of the brain, okay, with a delayed onset of signs and symptoms, right? What are our 3 different types of brain bleeds?
Subdural.
Uh-huh.
Epidural.
Uh-huh.
And is it when it's like inside the brain?
So what do we call that if it's inside of the brain?
Intradural?
Not
That's
intradural.
yeah.
What's it called? What's it called?
Cranial?
Not intracranial,
Repeat the question.
Wait.
because cranium is just head.
Cerebral?
Right, intracerebral. So, Mr. Fox, okay, how would you describe the speed of an epidural bleed?
And epidural is super fast
Why?
because the vessels are just bigger, so it allows more stuff to go out faster.
What about subdural?
It's going to be the slowest one because they're the smallest of the vessels, so it's slower bleed.
Nope. Why are subdural slow?
I was thinking the same thing.
Mm-mm.
It's a venous.
Right, it's a venous
Oh,
bleed.
It's a
Okay.
spine way.
Right. Whereas intracerebral bleeds are,
They're not super fast, but they're fast.
why are they fast and not super fast?
Because they're smaller than the ones that are at the top. That
Right. Yeah, they're smaller arteries. Okay. Now, the patient who's got a subdural bleed with a geriatric patient, okay, again, they're going to have a delayed onset of signs or symptoms. So you could have grandpa who falls and hits their head, and it's totally fine besides, oh, I got a headache right now, but they're not going to show any neurological deficits. Okay, now with us, if we get a subdural, it's going to take a little bit. Let's just say, for number's sake, 2 hours before we start showing symptoms. Grandpa may take 8 hours before you start showing symptoms. So if you don't assess the MOI properly, like, okay, old man, you just hit your head, got a little headache, you don't want to go to the hospital, all right, fine with me. And the next thing you know, you get called out about 8 hours later for a full arrest, right, for patients who are showing signs of Cushing's triad. Okay, so we have to be on the lookout for that and just be like, hey, you know, you may feel fine right now, but we'd like to take you to the hospital just to go get checked out. They'll do a scan of your head and make sure there's no bleeding. If there is, they'll fix it. If not, then they'll send you right back home, right? Again, are all old people going to want to go to the hospital? No. Okay, so we have to try to convince them as much as we can, all the way going up to and including the risks of death, right? And if you don't go, again, you're probably going to die.
So does CS come back? Like, is it like?
Can it regenerate?
Yeah.
Yes.
Okay.
Yeah. Okay, that's why kids, if they are lacking CSF, what are we going to see to indicate that?
Their eyes would be sunken.
Not their eyes.
It's the spina bifida.
Nope.
Oh.
They're fontanelles?
Yeah.
They're fontanelles. And what are the fontanelles?
Specifically, I know they stop growing after 18 months.
Okay, but what are
I
they?
don't know what they are.
What are they?
They're basically openings in between there are like yet to close areas of our skull.
Right. What do people call them in babies?
Fontanelle?
That's what they are, technically. It's a medical term. But your mom's going to be like, oh, look at my baby's fontanelles. Right? Maybe something else.
Oh.
What's
The fontanelles on that one.
I don't know what they're called.
Soft spots?
Soft spots.
Oh.
Yeah. Okay. So again, those are the soft spots in the baby's head. Okay. And if the baby has sunken fontanelles, is that an early, mild, or early, medium, or late sign of dehydration? That's a late sign. Okay. Because again, they've lost so much fluid that the fluid around the brain itself is starting to be lost as well. Okay. Whereas if they have increasing ICP, they're going to have what kind of fontanelles?
Bulging?
Right. So what conditions can cause bulging fontanelles?
Hypertension?
We're back right now.
Which is going to lead to what inside of the head?
What was your question there?
What's going to cause bulging fontanelles?
Meningitis?
Right. So what signs would I see in an infant who has meningitis?
That they're not crying,
Okay. What else?
and then they have you said infant, right?
Mm-hmm.
Increased
What was the question?
What are we going to see with an infant who has meningitis?
So they're gonna have instead of, because they can't turn, they're gonna turn the whole body to turn away from stuff instead of just turning their head. They're gonna be irritable, but they'll just not be crying.
Okay.
And yeah, they'll turn away from light, and
Because they have.
they have photophobia
Uh-huh. And why are they not just turning their head?
because they have syphilis in the neck.
What do we call them?
I know it is.
And we also talked about it yesterday
I
morning.
know we did. I can't remember. I'm stuck with. Rigidity. Dude, but not picky. That's the trick. Spinal rigidity. No.
Nuclear rigidity.
Right, nuchal rigidity. Okay, so that baby's gonna have nuchal rigidity, that stiff neck, photophobia, so they turn away from the light source. They can be very fussy, but they're not gonna be what? Crying. And they're gonna have what kind of fontanelle? Bulging fontanelle.
Is that
Okay.
the corner of the
Well, it depends on how many they have that are open.
Oh, I
Yeah.
thought it was specific ones versus the
Nope. If both are open, then it's the camel head. If it's just one, then it's just
Okay,
camel.
cool.
Yeah. Right. So, as far as meninges, right, then that's where we're going to go and see with that. So, just tying it back to it. So, when it comes to neuropathy, okay, neuropathy is going to be degradation of the nervous system, causing death of the nerve tissue. Okay, so patients, when their nerve cells are dying, okay, those nerve cells are going to be sending out pain signals. So they're going to be complaining of pain wherever the neuropathy is occurring. Usually, it's going to be the hands and their feet first, especially if our patient has diabetes. Once those nerve cells are completely dead, can they send out pain signals?
No.
So what's your patient going to feel?
Nothing.
Nothing, right? They're going to have numbness in those areas. And again, with diabetics, we usually are going to see that in the feet, possibly even the hands. Yes?
Is there any like showing signs of like neuropathy? Because like I know when you get like frostbite, like you can see the signs and those things are killed. Is
No,
it just
because
look
circulation's
like
fine. It's just the nerves aren't going to be...
that? So you can like just touch hot shit and it won't fuck them.
yeah,
Don't
yeah.
feel it.
Especially if the nerve cells are completely dead. They don't feel pain.
So it's that, does it also make those extremities dry? Like really dry?
What?
The neuropathy? I'm in diabetes.
No. All right, so when it comes to different parts of neuropathy, okay, that's where we get things like dementia and Alzheimer's, okay, because there's nerve cells, right, are dying off, okay, and the more nerve cells that die, the more serious those complications are. So when it comes to dementia, okay, dementia is a slow progressive onset of an ALOC, and dementia is really an umbrella term for that kind of stuff. Okay, so dementia is a slow progressive onset of an ALOC. So again, that's an umbrella term, and there can be multiple causes of dementia. So Alzheimer's can lead to dementia. Some people just call it Alzheimer's/dementia. That's fine. It can be caused by CVAs. Okay, so the complications following a stroke obviously are going to kill more nerve tissue. Depending on what part of the brain it's affecting, patients may start to develop dementia. And genetic factors. If you got a family history of it, you're more likely to get it.
So would dementia be considered functional?
It depends on the cause. Yeah. So it depends on the cause. If it's caused by CVA, again, that's a physical issue, right? As far as Alzheimer's and genetic factors, that would be more functional because the wiring is messed up, right? Drugs, kind of like schizophrenia, right? Drug usage in younger age can also lead to dementia.
Wait, isn't Alzheimer's the one where you start like forgetting stuff? Like you like, oh, well, like they think like they're back in like something that happened. In the
Yeah,
past.
but again, dementia is just an umbrella term for the slow progressive onset. All right, so when it comes to that, again, slow progressive, okay, it cannot be reversed. All right, so it can't be reversed. It can be slowed down a little bit in some cases, but it can't be stopped and fixed. All right, because once nerve cells are dead, can they be replaced?
No.
Can they be revived?
No.
No, right? We start having dying off of nerve cells, which is what your brain is, right? Going from there. So with dementia, the patient will start to have loss of cognitive abilities, i.e. memory loss, right? The lack of psychomotor skills, so they may not be able to grab onto things, right? They become very clumsy, can't take after themselves, and a decrease in social skills. And this is why we have that social assessment in the GEMS diamond. Okay, we want to see if they're more social, if they go out and do things, or do they have people coming in to check in on them? Right, because again, these patients may not be able to do things for themselves. Okay, so as far as the cognitive abilities, it starts off with your, short-term memory loss, like, oh dang, grandma keeps forgetting where she puts her purse. Right? It starts off with that, and then eventually it goes to, oh dang, grandma doesn't know who her grandkids anymore. Right? And again, as far as how quickly it goes on, it just depends on how bad it is. Psychomotor skills, again, they may not be able to do things for themselves, so they may be able to grab onto things. They cannot eat, can't drink, can't walk. And social skills, again, they start to become hermits, where they don't really want to go out and socialize and interact. Right? And they start to have things like mood swings and stuff like that. Okay, and this is a slow progressive onset that will gradually start building up as time goes on. So, short-term goes to long-term memory loss, like we just said. Okay, they have decreased attention spans, so they can't really focus on things for very long. Can't do daily routines such as bathing themselves, cleaning after themselves, changing, stuff like that. Okay, they don't clean their house, so that's where we see a lot of things like hoarding start to develop in dementia patients. All right, they can't communicate to the point where these patients may be nonverbal. Okay, so they can't talk. Maybe they can point or do some other stuff, but they can't communicate with us verbally. Confused or angry, having mood swings, impaired judgment, so they'll do things that just don't make sense. All right, and they might not be able to vocalize pain, especially if they're nonverbal. Okay, so an example of a patient who may have dementia would be people like your crazy cat lady. Right, where she's got a bunch of different cats. Right, house is a mess, smells like cat piss. Right, they're running all over the place. Right, and depending on what universe she lives on, speaks gibberish and throws cats at people. Right, so okay, those are all signs of dementia, maybe assault. Right, but that's what we're going to be looking out for. Now, sometimes these patients are going to have family looking after them. Okay, and again, we ask them, okay, what's normal for them? So we can identify abnormal. Oh, yeah, my dad normally knows his name and he knows where he's at. He just doesn't know the day of the week, doesn't know time. Okay, that's fine.
Is there ever a point where it gets so bad that, like, normal, you can't tell the difference between normal and something abnormal?
Especially if they're nonverbal, yeah. Right? Because again, there's really no way of knowing. They just seem more out of it than usual.
So they're still AO3 if they don't. No, okay.
No. It's just they're technically altered, right? But we don't treat them as an altered patient. Where I go and give them high flow to stroke assessments, things like that, if they got a history of dementia. It's like, okay, well, that's just how they are. Right? Now, as far as delirium is a sudden onset of an ALOC. And with delirium, this is usually reversible. So dementia, slow, progressive, irreversible. Delirium, sudden onset, usually reversible. This is where we run our AEIU TIPS mnemonic. Okay, and the geriatric patient. They have time to develop chronic alcoholism. So do I have to worry about delirium tremens?
Mm-hmm.
Yeah. All right, and again, that's those patients that need a bottle of Jack a day just to function, right? Let alone catch a buzz or anything like that. Okay, and if all of a sudden they stop and go cold turkey, that's where they start experiencing DTs. Okay, withdrawal from sedatives as well, hypoglycemia, right? Diabetes is more common in geriatrics because their endocrine system is not as sharp as it is when they're younger. Okay, so their pancreas is like, I don't really want to make insulin as much anymore, or I don't want to make that well of insulin. Okay, crappy diets leading to type 2 diabetes. Right, so we do have to worry about that in diabetics too, or geriatrics. Psychiatric disorders such as depression, we'll talk about that in a little bit. Environmental issues, again, young people and old people don't do so well in those extreme environments. Okay, with younger kids, their compensatory mechanisms haven't developed yet, whereas geriatric patients, their compensatory mechanisms are deteriorating. Okay, so obviously older people can shiver because they are able to do that, they just don't do it very well for very long. All right, they have thinner skin, things like that. Okay, so it's going to cause them to have more serious environmental issues earlier on. All right, as far as syncope, all right, that's when patients pass out. So syncope is common in geriatrics, especially if they are straining to have a valve movement. Okay, where they push really hard, stimulate that vagus nerve, and then lose consciousness due to bradycardia. Can geriatric patients tolerate bradycardia very well? No. Okay, so that can be enough to where they end up dying on the toilet. And again, that is a very shitty way to die.
Is that not usually for all of them?
No, WMDs is my top. Alright. So, as far as that is going to be quite common in geriatrics. So we are, unfortunately, it's kind of common that we run a cardiac arrest in or near the bathroom, right, for patients who have, again, died on the toilet. All right, and if they do pass out and they wake up, now we got to worry about head injuries of them hitting the sink, falling face first, things like that. Okay, and of course we got to worry about brain bleeds and whatnot. All right, and we'll take our break here. So we'll come back at 8:05. There.
Not ever. Are we going to just do this, or are we going to do paper?
What's up?
Or am I going to do paper?
You're going to do paper.
Yeah, shoot. I don't have a jacket today. I don't have a jacket today.
That's why. Because I like to hold my toes weird. Yeah. Like I like hold my toes up like this. I don't know. Or I go like this. I can
Respiratory. Okay, so these are going to be gases. All right, so chlorine gas, phosgene gas, okay, things like that. Obviously, with chemical gas inhalation, right, we're going to lead to pulmonary edema. So with this, we just do the best we can. All right, try to maintain the airway as best as possible. If they have fluid secretions in the airway, what do we do?
Suction.
And if it goes right back, what do we do?
Wait 2 minutes.
Ventilate for 2 minutes, and then we go back and do it again. Okay, we're going to talk about different levels of protection as well tomorrow, but level A is the highest level of protection that's available. We don't get level A suits. Okay, this is an example of a level A suit.
That's like Chernobyl shit.
Yep.
Can I get
Can I buy those personally and pull up the site with it? Because I
I've run a few
that
with
was
you
my
too.
Apple.
You fucking prick. Nope.
All right, just pull out your backpack. Save this for rainy day.
I just wear it everywhere, just in case.
So,
COVID safe.
we just want to go ahead and transport these patients. All right, get them secured. As far as nerve agents, okay, these are going to go after what system?
Nervous system.
Nervous system. Okay, now with the nerve agents, these are the most lethal type of WMDs there are because it can kill people in a matter of seconds, right, or just a couple of minutes. Okay, so it will kill people very, very quickly. Now, these nerve agents work by going in and blocking receptors for the sympathetic response, which means they shift all the way over to what response?
Sympathetic.
Parasympathetic, because their sympathetic is blocked.
Oh.
Okay, so these are essentially the same as your cholinergic agents, right, or your organophosphates. Okay, so with that, what kind of medications could we give if our patients have been exposed to nerve agents or organophosphates?
Anti-cholinergic agents.
Okay, such as
Nope.
such as
There's the models, like there's Mark 1.
Okay.
And then the duodotes.
okay. So what medications are in those autoinjectors?
Atropine and Braxofline. I don't. That second one didn't stay here.
Yeah, atropine is one of them. What's the other one? What's the other one? What's the other one?
It's paradoxin.
Right, pralidoxine.
Pralidoxine.
Okay, so with our Mark 1 auto, with the chemical agents, okay, the nerve agents, right? What they're going to do is they go in and they block receptors for us to activate the sympathetic response. Okay, so they block one of the primary neurotransmitters, acetylcholine. Okay, hence where we get the cholinergics and anticholinergics. Okay, so they go in and block those receptors, right? So molecules can't activate the sympathetic response. If I were to give the patient epi, is it going to do anything? No, right? Because the receptors that epinephrine would bind to are blocked by these organophosphates / nerve agents. Okay, so again, medications, they're on switches or off switches. Your organophosphates are off switches, right, for your sympathetic response. Okay, so you can stab them with as much epinephrine as you want.
We can.
No. Okay, saying that you could, it's not going to work.
But then as soon as you give them the...
So you just give them, the duodote or the
So if you
Mark
set them
1,
up with an
it all
Advil
goes in.
beforehand, and then you hit them with the
No.
Mark 1, and then...
Don't do that.
No, we don't need to hit them with epi. Right? All we have to do is open up the receptors, and they'll take over and do what they have to do.
Question. Out of those three, would it be better to get hit with nerve agents because you don't feel it as much? Because it's hitting your nervous system?
You're gonna die.
Well, I know I'm gonna die, but I would rather not have like blisters in my lungs or dying of fluid in my lungs. I'd rather die of this.
I mean,
right? This is
It's not like you
the
just-
way you want to die is specific to you. So
Well, I'm saying
that's
like
fine.
out of all these, like this is the best one we want to hit with because we can treat this one. Unlike the pulmonary agents, there's no antidote. This one we can get hit with something and possibly survive. Yeah? No?
No, because again, it kills you in a matter of seconds.
But
when you die, but when you die, right? What are the mnemonics that we use to indicate this?
Well, yeah,
What are
shitty
they?
when die.
Yeah.
But I'm saying.
So what are
like,
the mnemonics?
It's Sledgem dumbbells.
All right, sledgem and dumbbells. Okay, so you start secreting fluids from all your different orifices, right? You seize, you piss yourself, you shit yourself, you start vomiting.
Second.
You're still dying.
Better than
agonized.
drowning. Or
I'll spray you
blisters in
with
my
Raid and
lungs.
we'll see how you feel. Let's do that. Go ahead, George.
What was the second chemical in the deal with that? Just atropine and what?
Atropine and pralidoxine. Right? So those will go in and they open up those receptors, right? And they keep them open. That way the body can still activate a sympathetic response. Yeah, even though we normally hang out parasympathetic, too much of anything is bad. And you go all the way to parasympathetic, that's bad. Okay? So, as far as our mnemonics, okay, so sledgem is military, dumbbells is medical. Again, it doesn't really matter, it's the same stuff. All right, but it's going to be all the different signs that we see. So salivation, excessive drooling, sweating, obviously sweating out like crazy. Okay, now even though they are activating the parasympathetic, and usually you're dry and parasympathetic, okay, it just causes everything to start coming out of everywhere. Okay, so we start losing fluids from every single orifice that we have, okay, including our sweat glands. Right, patients are going to have lacrimation, so excessive tearing, as well as rhinorrhea. Okay, so they have a runny nose, urination, peeing themselves, defecation, pooping themselves, along with diarrhea, drooling already covered, gastric upset and cramps. So all of your muscles also start spasming. Okay, so that's why we start getting seizure activity, right? Muscle twitching, and meiosis, pinpoint pupils.
Yeah, that sounds better than drowning.
I don't want to die, so.
So, with dumbbells, pretty much all the same stuff there. All right, so we'll go and hit the patients with the duodote with the Mark 1 auto injector kit. And who else gets hit with these things?
Ourselves.
We do, right? And we get hit first before we start hitting them, so we gather our immunity, right? So we can go ahead and treat those patients.
So I got yelled at again because Matt said we do not hit them with these. And
Yeah.
I was like, then how do we help them? He said, you help yourself.
Yeah.
And-
First.
But we don't help them.
That's what he
First.
said.
He
You
said
help
he
yourself.
definitely said that.
He
that
said,
we
yeah,
don't-
he was
I think
yelling
Max
at
likes
us.
to yell at us
He was yelling at us. He was saying that you shouldn't be hitting them with it.
Yeah.
That they should, like, you can give it to them to hit themselves, but you can't give it to them.
Let's just doing this. We'll just have to do that. Right?
Also, bigger question. So we hit as a nerve agent, right? Do we wait till we get on scene to hit ourselves, or we like as we're pulling out, we're like, I'm just gonna real quick and then like get into the
We do it
flame.
we do it close before we're going in, because if we do it, okay, we get dispatched. By the time we get there, it's going to run out. 'Cause I don't know the half-life of these. I don't know how long they last. But I don't want to sit there and give it too early, and then it runs out, and then now I'm.
That's what I'm wondering, because like you said, like you can die in seconds. Like how do we know when to hit it? Because if
Do it
I
right
get
there.
exposed to quickly.
Yeah. He also says that we have it in our ambulance. I've never had it in my ambulance. So.
Wait a second. That's cool.
Can we,
That
can we,
sounds like-
can we keep it in our pocket like a deputy?
I agree with that.
How much does it cost?
Yeah, I can buy myself like 5 of them.
Well, this you joined the military for. This one I don't know.
I'm literally gonna sign up right now just so I don't die.
If I'm going into oil, I'm going to
So, as far as right, these medications, okay, we go ahead and use them to reverse the effects of the organophosphate or nerve agents, right, to go ahead and allow the body to start kicking sympathetic. As far as metabolic agents, again, these go after the body's ability to use oxygen. Okay, so very similar to how carbon monoxide kills people, right? Same thing with the metabolic agents. Okay, so things like cyanide, right, are going to bind to the red blood cell and not allow oxygen to be used. Right. Okay. So with this, we actually do have antidotes for cyanide poisoning. Right. Usually don't carry it.
Oh.
Right. But with the Mark 1 auto injector kits and things like that, and cyanide antidotes, okay, they're going to be held in caches or caches, whatever you want to pronounce them, right, at places where the stuff's going to be found. So because it's found in industrial settings, there's probably going to be quite a few of them at supply at the place where they're going to be using cyanide, just in case, right, there's exposure.
So if you need them, will you just like call up like this and be like, yo, I need to do that right now.
We go and contact supervisors or anything like
Or
that.
we just like,
Yeah. All right. So, as far as the antidote, there it is. Right. So it's going to be a kit that will go and administer, right, to reverse the effects of it. Now, if we are transporting patients, okay, we have to take off all the clothing and leave them on scene, because it may leave or create what's known as off-gassing, where it's going to have a delayed, essentially, evaporation as a transport. Right. So it's bad if it's on scene. It's much worse when you're in a tiny little enclosed ambulance as you're driving. Right. So we just leave all the clothes there. Right. Transport to the hospital.
Strip?
Right. Yep. Okay. And we go from there. Now, as far as our biological agents, we have, again, bacteria, viruses, neurotoxins. There are some terms we have to cover in relation to that. So first off is communicability, which is how it is spread around the population, or how easily it's spread around the population, rather. Okay, so communicability, how easily it's spread around the population. All right, incubation is from the time of getting exposed to the time of usually showing symptoms. Okay, so the time when the patient's been exposed to the biological agent to the time they start showing symptoms. Okay, that's the incubation period. And then dissemination is how it's spread around the population. So communicability, how easily it spreads from one person to the next. Dissemination is how it was spread from one person to the next.
So would like mad cow disease be considered this?
If it's weaponized and targeted, yes. Right. So, we'll go over viruses first. Okay, so virus is going to take over a healthy cell, right, and use it to replicate and spread around the body. Should be familiar. Right. Now, with viruses, okay, as well as bacterial infections, they start off with generic flu-like signs or symptoms a vast majority of the time. So when the patient starts showing early signs of a viral or bacterial infection, they just feel what?
Shitty.
Sick. Yeah. They just feel kind of run down. And then later on, that's when that specific virus or bacteria starts showing its very specific signs or symptoms. Okay, viruses are obviously viral, so they can spread very easily from one person to the next, right, through different ways. So, smallpox, right, is a virus that can be weaponized, right, and smallpox is very communicable, where it can be very easily spread from one person to the next. It can be spread via respiratory droplets, so patients who are coughing or sneezing, if we inhale those droplets, right, we get exposed. If we come into contact with open sores, right, and we get the fluids, okay, on our body, we can then get sick with smallpox. Okay, so with these patients, okay, you want to make sure that you're wearing an N95 mask, right, and BSI from head to toe.
Don't accept blankets from white people.
If this were 300, 400 years ago, yes.
You don't know.
All right.
Grandma might got some bad intentions.
Well, smallpox is pretty much eradicated
Like,
here. So.
I needed you a nice little blanket. Bam.
Don't worry about it.
Nice little
Smallpox blankets.
All right, another one is viral hemorrhagic fever, or VHF. Okay, yes, with Ebola being the most infamous of them. Okay, now with these viral hemorrhagic fevers, okay, based on the name of hemorrhagic, what's the patient going to start to do?
Lose blood.
Bleed. Yeah, and they start to bleed from everywhere. Okay, both internal and external bleeding. All right, so obviously, quite a few years back, Ebola, right, was kind of going around a little bit. So with these viral hemorrhagic fevers, they are spread through direct contact with blood and other body fluids. Okay, but they may also be secreted via respiratory droplets if they have, blood in their airway and they start coughing. Okay, they can start putting droplets out in the air, and if we inhale it, then we can get sick with it as well. Coughing up blood. Right. So with these patients, same deal. N95 mask. Okay, don't come into contact with their body fluids. Okay, so make sure you are BSI'd up from head to toe.
Question. This is like these, especially with like viruses and viral diseases like this. In our questioning, say like in a secondary assessment, would it be viable to ask them if they've been out of the country or anything
Absolutely.
like that?
Yep.
Like have you been like?
Early days of COVID, that's what we were taught to
So
ask.
where would you put that? You store it wherever.
Throw it wherever we can. Maybe pee
Put it in
sample.
medical history.
Yeah.
Alright, yo, you've been to South Africa.
Yep.
Yeah, no,
So,
fuck off.
yeah, we'll just ask any of those questions. And like I said, early days of COVID, we'd ask, you've been out of the country anytime recently in the last 2 weeks?
You went to China?
Right.
I am.
So, with bacterial infections, okay, the good thing about bacterial infections, at least most bacterial infections, they can be fought with what? They can be
Antibiotics.
fought with antibiotics. Okay, and as long as they're caught early enough, right, usually patients have a good chance of surviving. But if we wait too long, then depending on the infection, they may not have that great of a chance. Okay, now with viruses, they usually don't live outside the body for very long. With bacteria, depending on what it is, they might be able to live a little bit longer. Okay, they also start off with generic flu-like signs or symptoms. Okay, so we don't really know what it is until we see what it is. So anthrax, okay, is a bacteria, right? And shortly after 9/11, it was used. All right, it's kind of scary to think that some of you weren't even alive at that time. So, as far as
2001.
yeah,
I was like one.
When did 9/11 happen?
I mean, I wasn't old.
so
Just think.
Born before 9/11.
Oh
That
my
fucked me
god.
up.
I've always wanted to be a history teacher, and I guess now technically I am.
Wow.
Alright, so-
like back in the day when we opened
Yeah.
letters,
You give
we
off
could
history
die.
vibes.
What's up?
You give off history teacher vibes.
I do. So, as far as I just wouldn't survive in a public school area. So, I get sued too many times. So, as far as anthrax, okay, it is going to be spread via inhalation, okay, which is again what was happening shortly after 9/11. People inhale the spores, or it can come into contact with skin and cause cutaneous anthrax. Now, between pulmonary and cutaneous anthrax, which one do you think is worse?
Pulmonary.
Pulmonary,
Die real quick.
right? But because it is a bacterial infection, as long as we catch it early enough, it can be fought off with antibiotics.
Wasn't anthrax like the one like if you like inhale it, you're like you're a goner. It was only if you got through the skin that you could.
Fairly quick, right? But again, if you realize, oh shit, white powder, oh yeah, I read on the news that they were doing this, let me go to the hospital.
Wow, $1 million.
Make sure you're good. Yeah. All right, well just don't be a politician or use
Huge black sores.
Yeah, that's what cutaneous anthrax would be.
Oh, wow. Okay.
So, as far as the plague, it is the same plague that was taught in history class again, history teacher. So,
Like the black plague?
yes,
Yeah.
all right,
Bubonic.
yeah, bubonic and pneumonic. So, bubonic plague, right, is going to have the big boobos, right? They're going to be developing on the skin. That's one of those fun words to say. All right. So, with the bubonic form, yeah, again, it can kill you, but Again, we catch it early enough. We know it's a bacterial infection now. We can go through with antibiotics, right? With pneumonic, okay, plague, that one will kill you in a matter of hours if you inhale it.
This is more of a history question. What happened to the third type of plague that was like 99% fatal?
Ooh,
That's just like liquid.
I have an answer.
From inside out.
I have an answer.
No. Was it around the same time?
Yeah.
Isn't it called the rats?
I actually
Yes.
found this out recently. So it was actually found out the only way you can really get that is actually eating the animals that carried it. And so it was found out that it started showing up again recently in Asian immigrants in like port towns. They started eating guinea pig livers or stuff like that, and then they'd get it and they'd die.
Cool.
Yeah, I remember them saying for years it was fleas, right? They were biting people, which makes sense, vector-borne illnesses, right? But it is what it is. Anyways, we just treat it with whatever we can and then go and they fix them with antibiotics. As far as neurotoxins, okay, so the other night we talked about neurotoxins from animals, okay, but tonight we're going to talk about it from plants. Okay, does the exact same thing, right? Doesn't matter where the neurotoxin's coming from, it's going to affect what body system?
Nervous system.
Nervous system. Okay, so it's going to go ahead and shut down the nerves, right, causing muscle cramping and respiratory issues, just like if the patient were to be stung by a jellyfish or be bit by a black widow, right, or any of the animals that carry neurotoxins. Okay, now with neurotoxins, right, even though they're super duper dangerous and super duper deadly, they're not communicable. Okay, they cannot be spread from one person to the next. Okay, so if a patient were to be infected with one of these, right, they could spit on you, cough on you, bleed on you, do whatever, you wouldn't get.
Spitting on someone's a felony.
Yes, but again.
Well, they're gonna die laughing and be like, ha ha, I'm not saving your ass now.
All right.
Fuck you.
Just saying, right, that could happen. So, again, not contagious at all whatsoever, and these tend to have a rapid onset of signs or symptoms depending on the route in which it gets into the body. Okay, so one form of neurotoxin is ricin, okay, which is derived from the castor bean, so it does have to be kind of processed, but it is still natural. Right, and for you Breaking Bad fans, again, this should sound familiar. All right, so as far as ricin, again, quite stable. Hide it in an electrical socket for a while, right? And super duper toxic. Okay, it doesn't take a lot to kill somebody. Right? KGB used it to kill a couple people, right? Back in the Cold War, right? They didn't know until recently, right, what it actually was. So again, pretty undercover stuff. As far as botulinum, okay, this is going to be produced from different type of bacteria in things like improperly canned foods. Okay, so foods that are not preserved properly, right, can lead to botulinum. And a slightly stabilized form of botulinum is known as Botox. Right? So, with Botox, again, it paralyzes muscles, right? Whereas botulinum, it's a neurotoxin, which means it paralyzes
everything.
Muscles, primarily your respiratory. Right? Now, as far as detecting botulinum in improperly canned foods, okay, that's why the cans have that button, right, that shouldn't pop out until it's been exposed, right? Because those cans are going to be vacuum sealed.
Wait, button?
Yeah, like
on top of the can.
You have like a mason jar lid that's depressed, and when you open it up, it pops.
Wait, that's a thing?
Yeah.
Mm-hmm.
Oh,
Like in jam.
wait.
I worry about him.
Yeah,
Wait,
we're about
like,
your
wait,
kids.
it's like, wait, if your jar pops,
It's not like a literal button. It's just
What's
like
up?
So like your jar, if you open it, it pops. It's bad.
No, it's a good thing. Yeah. If you open it and it
jar of
doesn't
jam or
pop.
something,
And it's like it opens and it's
Just a
nice and
little
easy.
button.
Open
Yeah.
the formula and
And like
go-
bond stuff and it just opens quiet and it's nice. That's bad.
It's usually bad, yes. Especially if it's bulging out. Okay, now again, usually opens in home canning, not hand canning, home canning, maybe canned hams, right? But home canning, okay? So if your neighbor's making, you know, a jar of peach preserves or whatever, and they're like, hey, here you go, and the lid is bulged out, okay, should you eat it?
No.
No, be like, thanks, right, and then throw it away, okay, because it's probably going to be tainted with botulinum.
You can't be. What if it's just like
I'm
pressure?
trying to get it.
What's up?
Botulism versus botulinum is what's
Botulinum is just the bacteria.
okay.
Yeah. All right. So we don't want to eat that because it will kill you. All right. So again, make sure you check your foods. So as far as radiation, okay, we got our 4 different types: alpha, beta, neutron, and gamma radiation. Okay, alpha, beta, super duper weak. Gamma, neutron radiation, super duper strong, super penetrating. Okay, so if our patients are exposed to the latter of the two, okay, that's where we start to see a lot of our radiation injuries, radiation burns, and whatnot. And when it comes to the assessment of radiation burns, Chris, what do you have to think of for assessment of radiation burns? And
How
exposure
far
to radiation.
how far away they were.
Okay.
The time of the exposure.
Okay.
And what was between them and the
Right.
radiation?
Okay,
And
so shielding, time, distance.
are they green and huge?
No. Right, so shielding, time, and distance. Okay, so how much stuff did they have between them and the radioactive source? How long were they exposed to the radioactive source? And how far away were they from the radioactive source? Again, STDs. Okay, and we want to think of the same thing for ourselves. We want to have as much shielding as we possibly can. Right, we want to spend as little time as possible exposed to the source and get as far away as we possibly can from the source as well. Yeah.
Would certain materials work better as reflective? Like if someone was like he's holding like his clothes and whatnot, like if they had like tinfoil on them like crazy people, would that like reflect stuff better?
Would it work better?
Lead. Yeah.
Oh.
So as far as locations where we're going to find these, okay, it's super duper rare that we're going to have to deal with it, but again, may happen. Anywhere there's radiation, we'd have to worry about the possibility of radiologic exposure. Okay. Now, when it comes to dirty bombs, okay, or radiologic dispersal devices, these are conventional explosives. Okay, so regular bomb, okay, that's gonna have radioactive material packed around the outside, around the outside, around the outside. Okay. Take it easy, Brent. Take it easy. So, right, when these things explode, we have the conventional explosive, which again is the most potent form of weapons of mass destruction. Okay, but then we have all the other radioactive particles that are going out. Right. Now, as far as that sense, okay, it's not really the best form of a WMD when it comes to trying to spread as much radiation as possible, because it only works if the patient were to get hit by the radioactive material. Okay, but it's usually the blast injury that's going to cause more death, damage, and injury.
So with like, okay, so I know that there's a certain thing for like when they explode nukes, they explode it above the ground because it actually causes more damage because it aerates.
Yeah.
So is that the same as these?
Nope. No, because these are again conventional explosives, regular bombs with
like
stuff
TNT,
around the outside.
like wrapped around with like radiologic stuff and tucking it.
Pretty much. Okay.
I have TNT.
Yeah.
Why?
So, when it comes to nuclear energy, that's what you're talking about, right? And will we know if a nuke goes off?
Yes.
Maybe.
Yes.
I hope so.
Okay.
Oh my
Right.
God.
We will definitely know when that happens. Right. So it's going to be pretty
I'm not
obvious,
going
and that's where you have to worry about things like fallout and whatnot. Okay. Whereas the radiologic dispersal device, again, it's a regular bomb with radioactive shrapnel that goes flying out.
Make sure you have a
So would this really, like, if a nuke went off over LA, would we really be like, do we have to go? I can't go to like a bunker and like chill out because
I mean,
my
technically
supervisor's
you
probably
can.
gonna be dead anyways. I'm not gonna get in trouble.
No, but I mean, you still
society
should go
collapses,
there.
There's no societal ramifications. But like,
So, as far as deconning these patients, again, it's all about hazmat. Okay, so hazmat's going to be the one to go in and decontaminate patients. Okay, we'll talk about what they're going to be doing tomorrow. But we want to make sure we have proper PPE, personal protective equipment, that keeps you from getting hurt,
PPEs.
because BSI keeps us from getting sick. Okay, and I may want to wear a BSI under my PPE, just to make sure that we don't get hurt and sick. So, with radioactive issues, again, shielding, time, distance. Okay, so just think about those different types of assessments. How much stuff did they have between them and the source? How long were they exposed? How far were they? And we want to be as far away as possible with as much shielding and spending as little time as possible. All right, with our blast injuries, again, the primary blast injuries, the actual shock wave, okay, that causes damage, does most of the damage to us. Secondary blast injury is going to be shrapnel flying through the air. Okay, it could cause penetrating injuries, depending on how fast and how small it is, or blunt injuries, depending on how slow or how big it is. Okay, we've got tertiary impact, with the patient flying through the air, impacting certain things, and then quaternary is anything else caused by the blast. Burns, smoke inhalation, chemical inhalation, usually crush injuries fall into that as well. Okay, so anything that's not one of the major three, but still attributed to the blast, is a quaternary blast injury. With blast injuries, you've got to worry about neurological injuries, especially to the brain and the spinal cord. Okay, traumatic amputations of limbs are super duper common. Obviously, different types of bleeding, ruptures of internal organs. Okay, all that really bad stuff that we're going to see with explosions. As far as points of distribution, if we're not near the actual event itself, we may be called to assist and send resources to other places, right? Kind of a mutual aid response, right? So they're going to have these stockpiles all around the country where they can push supplies by ground anywhere within about 12 hours. So they're all located around the country, right? So if we have something going on in Central California, where it's a big, massive disaster with thousands and thousands and thousands of patients, okay, we may be shipped over there, or we just be made told, hey, you know, you guys over here on this shift at this company, you guys are going to go and start prepping these stockpiles to go and send out.
I'm sure there's
Right.
that many people in
This is what
Central
we talking
California.
about in
though.
that thing, huh?
This is
There
an
are.
example.
Isn't this what
A
they were
lot of
talking
just
about in that
farmers.
thing you had us do, the certificate?
Yeah.
Probably.
ICS.
Yeah.
It is an ICS.
It
Yeah.
was.
ICS usually
Alright.
does cover this kind of stuff.
Yeah, I haven't done it in years, so I don't know. So as far as these, we may be doing this, right? We may be called out to, again, go work in other places doing these large scale events, right? So then let me change it to San Francisco then. How about that?
Yep.
All right,
Oh,
so.
no, I think I
live
let
in
them
Central
die.
California.
Okay, so as far as that, right, we may have to go do that. Okay, 9/11, right? People from all over the country were going over to New York, right? So again, that'd be an example of that stuff. As far as syndromic surveillance, that is essentially kind of looking at things retroactively to determine what may be going on. So let's say, for example, that there was a, I don't know, chemical attack at a concert. Okay, so it was very discreet, there's no explosion, nothing like that, everyone's there, no one's feeling symptoms until 2 days later. And then all of a sudden, right, all these hospitals that are in the area start getting this massive influx of patients that are complaining of the same thing. Right? And then we kind of start listening to the patients. Oh yeah, I went to this concert. I went to this concert. I went to this concert. And like, oh shit. Right? And then they start calling other hospitals like, hey, are you guys seeing this kind of stuff? Yeah, I thought we were the only ones. Oh shit, something happened. Right? And we kind of go back and do that stuff retroactively. It's very similar to what happens with like food recalls. Right? Oh, you had this particular brand of spinach, right, from this lot number, from this range to this range. Kind of the same deal. All right? But we're doing that in case of a WMD attack.
Would this really matter in certain situations? Like, okay, so like, say, yeah, if like a nuke or like a big chemical something when it happened, there's gonna be lasting effects. I understand that, but like, say something like the Boston bombing, you're not places
No.
12 hours away aren't gonna be like, oh, well, let's
It
come
just
over there because by the time they get
magnitude.
there, it'll be over, right?
Yeah, it depends on things like that. So it's not like it's going to happen all the time, but again, those larger scale, long-term issues, yeah, they may start sending things out, right? Where it may be a 12+ hour situation. All right. So go and start putting stuff away.
No way. Is that your fallout kit?
Hmm?
Is that your fallout kit?
Nope.
You got one?
I do.
You do?
Oh hell yeah.
Mine's just full of
I'm
bottle caps.
ready for this shit. I did not need. I didn't need that.
Going same tag. I actually have a fallout shelter right now.
I have a bunch of.
Like, yeah. I have a
Wait, you have the app?
Yeah.
Oh, Fallout. I have that.
I
It's so long.
I have, yeah.
I have. What do I
I
have?
feel like my factory
I have
is the best
guns.
one ever.
I have
That's fun.
lots of MREs. I have lots of medical supplies. In real life, yeah, I have guns, MREs. Yeah, I have.
I never played the app.
Man, my shit is so fire.
I have
It
a
was so
shotgun,
long.
and I have
I'm like really dragging. I feel like I exceeded the box.
and an M1.
What's the California compliant emblem?
So you just cannot alert. Yeah, and it's actually given like a sub range. Just the fact that it's not just synthetic, they just love that. They're like, oh, really? Wooden, yeah. If it's wooden, for some reason they're a lot more fun. No,
Nitro. What's the first thing we do for this drug?
Make sure it's prescribed to them.
So what mnemonic is that a part of? Mm-hmm. It is dice. Okay, so the drug's got to dice out, and then indications for nitro.
Trouble breathing.
Mm-mm.
53 bash.
Nope. So indications for nitro. George?
Overdose?
No. Axel?
Blood clot?
Nope.
Did we get somebody that's? Did somebody say breathing problems?
Nope.
Oh.
Brett? Nope. Daisy?
Is it diabetes?
Nope.
Acute non-traumatic chest pain.
Right. Okay. So then why didn't you say it? So right. As far as the contraindication or the indications, right? Acute chest pain meaning it's non-traumatic. Contraindications.
So it's 53 batch.
Okay, give me 5 and 3, please.
Only those two?
Yes.
Okay. If they had gotten a
know,
dose in
you
the last
finally
5
know
minutes,
something.
or if they had 3 doses per episode.
What's the definition of an episode?
That's from the start to the end. The start to the end of the symptoms.
Okay. What about B and A? George? Yeah.
Birth control.
Nope.
No.
Nana?
Blood pressure. If their blood pressure is
Oh.
Save you for that.
if their blood pressure is like lower than
I studied the other things that night.
I'm just tired and stupid.
Blood pressure is lower. No. Erica? Brent?
Systolic blood pressure is less than 100.
Right. And A?
A. I have S and H. Just
No.
kidding. Just kidding. Yeah, no, I don't got it.
Would it be apneic?
No.
Oh.
What's A?
I know it.
Fuck with me.
Well, that's not what I'm asking. What's A?
Is it ALS?
I don't know. Is it?
Is it?
This isn't Jeopardy, sir. Don't answer a question with a question.
It is.
Okay. Yes. ALOC.
Okay.
Okay. Ignacio, what about S and H?
Is it the patient has taken any sexually enhancing drug for it out?
Again. it
Yeah,
is-
it is.
Okay. And?
And head injury.
Okay. How would I rule out head trauma, sir?
Sorry?
How do I rule out head trauma?
I'm not sure.
Doing a rapid physical.
So what do we have to do?
You palpate the skull, feeling for any fractures,
Right.
look for
It's
respiratory
palpate.
stuff.
Okay.
Did you hit your head?
Right. Yeah, no, palpate. Okay, because if they hit their head, could they not remember they hit their head?
Yeah.
So we got to palpate. Okay, so we go ahead and check that, and then we go to administer. Where do we administer nitroglycerin?
Oh fuck. I'm thinking. Yeah, I'm thinking Narcan. Is it? Wait, hang on. Nitro is intranasal.
What do you mean orally? I'm sorry? So they swallow it?
Oh, I fucking remembered. Goddamn.
Is it a spray?
Could be.
Okay. Okay. Is it the one where you spray and you have to make sure it doesn't get on you?
Yeah.
Probably.
A lot more.
Can I redeem myself?
Under
No.
the tongue.
Right, so what route is that called?
Sublingual.
Right, so we go administer sublingual. How many sprays do I give at a time?
Wait. 3? 1.
At a time, you would just give one.
Right, how many tablets do I drop at a time?
How strong a trip do you want?
1.
One tablet equals 1 dose. 1 spray equals
One dose.
1 dose. And we place it where?
Sublingually.
Right, sublingually under the tongue. Okay, and then we go and prep for transport. Okay, go code 3, recess every 5 minutes with ALS in the back. Okay, all right, so, Cheyenne.
We're gonna do it on her?
No.
Yeah, let's do
Oh.
it.
I can give you some shrimp right now if you really want to test it out.
I'm not allergic.
That's too much paper. Dude.
Cashews, maybe.
Cashews.
We'll see. We'll see. Hopefully she can save herself. I'm having anaphylaxis. Please help.
Oh God.
Wait.
What the fuck? Okay. Is this yours?
Yeah.
Did your doctor give it to you?
Mm-hmm.
What's the dosage on here?
Well, it's an adult EpiPen, so what is the dosage?
Okay, it's 0.30. 0.3.
Okay.
Yeah.
She got stabbed.
I know.
I'm trying to think. Did we already go through dice, or do I have to go through dice with you?
I'm having anaphylaxis. Please help.
Have you already taken this?
No.
Okay. Okay, I'm gonna clean the area in a small circle, big circle.
Okay. Mm-hmm.
What's this thing? Sorry, I just took some inhalers, so I'm sitting here shaking.
Okay. Well, I'm dying, so please help.
1, 2, right? Oh, okay. And then, wait. I gotta expose your,
Okay.
I gotta expose your leg, and then I'm gonna stab you.
Oh my gosh! What did you do?
I just stabbed him.
Bro.
Take a seat.
Yeah.
Stab you?
No.
No, it's not a real needle.
George.
I don't know. I got a little scared right there. I thought Shane didn't kill him though. I was like, damn.
Having anaphylaxis please help.
It is yours?
Yeah.
Okay. Clean it.
Okay.
And then just leave it out and then wipe it again.
Okay.
And throw this away in a
That
Sharpie
expired
tin.
4 years ago, just to let you know.
Damn.
Well, damn, that sucks.
I want to
I'm dying at her.
Let's do a real one. Let's make this fun.
Hell no. No. I need patches in the computer.
Oh, a real one?
Having anaphylaxis please help.
No,
Is it
I wanna do
yours?
something I actually like.
Where I check the expiry date.
Say it's not expired.
Has someone almost died?
Let's eat some fish.
Have you taken it already?
Nope.
Clean the area.
Okay.
Smart so it goes to bed.
2, 3.
Throw it away.
Really? She's just gonna throw it in the trash for some
No,
kid to
in
grab?
where it goes.
Sir?
No.
No.
He's dead. He said nah.
I'm good.
I can't mess up if I don't do it.
I'm having anaphylaxis please help.
Have you taken this recently?
Mm-mm.
No. Is this prescribed? Is this prescribed to you?
Yep.
What dose is your? Okay. Dose is 0.3 milliliters.
Milligrams.
Milligrams. Okay. Checking expiration is my
Not expired.
not expired. Dice. What's the last thing in dice that I just heard and I forgot? Okay.
Just stab him.
Yeah.
It's okay. It'll be fine.
Stick out.
Oh, so the blue end is party dick.
And then I need to rub with the alcohol, small circles to big circles, and then expose the site, then stab. What? 2, 3.
All right, 10 seconds is up.
Okay.
Yeah.
You're good. And then I'm gonna throw this away in the sharps trash.
Take a seat.
Oh.
No words needed. Are you saying somebody else can kill you? Is that what you're trying to say?
Who kills him?
Is this dice stuff? This is yours?
Yeah, it's fine.
Have you taken any before?
Nope.
Okay.
Oh,
Looking good.
It's intact.
Intact. Gotcha.
I know.
Now, I don't know why I'm asking because you're dying, but does it matter which leg? I don't think so. Okay.
Help me.
Can I have you? Can you pretend pull down your pants, or do I need to come over? Okay, shorts. I pull up the shorts. Ready? 1, 2, 10.
Okay.
Oh my God, guys, let's clean the area. I had him take down his pants. Clean the
Well,
area.
no, you already missed it. Sorry.
I had that too.
I had the red button. You got the X on the line, bro.
You didn't even say anything new.
Chris going before. He's gonna do it. That's not fair.
I'll fuck it up for you just because.
Right? And be like, oh, that's not my
Subscribe to you.
Yep.
Checking the expiration date.
Not expired.
Not expired.
Actually, get t-shirt right
Okay, have you already taken this?
No.
Oh.
Can I give this to you?
That's what I called it for.
Okay, so it's the area. Clean it, small to big.
Okay.
Good. That's fine.
1, 2.
10 seconds.
Alright. I'm gonna expose it. Not expose it. Throw it away and the correct bin. And is it the hazard bin? No. Massage the area, making sure that it goes around the body eating.
That's it.
That's yours.
Take it home, bro.
This is it.
Oh, there's too much pressure now.
Not sure.
This is yours. Is it prepped for anaphylaxis?
Mm-hmm.
Okay. Is it expired?
Not expired.
Looks intact to me.
Yep.
I can't see the color clarity of it.
We'll say it's clear.
Cool.
Because you would be able to see liquid in most of them.
Really?
Yeah.
Cool.
But it's clear.
Okay, cool. You're having anaphylaxis. Can you please lift your shorts so I can clean the area? I clean small circles, big circles.
Okay.
Here we go. Like that. 1, 2, 10. Cool. I'm gonna throw this in charge, and you're in shock, so I'm gonna treat you for shock. So I'm gonna give you a blanket, O2, and lift you like 6 inches.
Thank you for killing me, sir.
What?
Almost.
It was my hopes. I'm not gonna get this.
I thought you wanted me to plug it up.
Not that bad. What? I don't know what I'm gonna do.
The same thing everyone else did.
First, let me give this to you because I can't hold this. You have to give it to me. You already gave it to me. Okay. Did your doctor prescribe this to you, sir?
He did.
Okay. Is this actually epinephrine?
It is.
Okay, it's not right dosage. This looks clear. Color is right. And then does it expire?
Not expired.
Not expired. Okay. So then, oh, I don't care if you have shorts. I'm cutting your shorts. Expose. Then I'm going to take a sterile alcohol wipe, rub from small circles to big circles. I wasn't here for this. Top it off. 1, 2,
That's
10.
didn't deploy.
Push harder.
Didn't deploy.
Just push harder.
Oh!
Go.
1, 2, 10.
Okay.
And I take it out. Then I would put this in the sharp and I'd start massaging you from small circles to big circles. I would apply bandage or dressing of some sort because you're bleeding.
Okay.
Fuck. Okay, I stopped the bleeding. You have that in you. Oh, do I check your vitals?
Okay. Then what?
Fuck. Yeah, so I made sure it all worked. And then I transport you code 3 to the hospital.
Okay.
And then I give him my
Okay. Well, what else are you gonna do for me?
I provide you high flow O2.
Okay. What else?
You can't do this to me. So I gave you high flow O2 because you're in shock. I do not elevate your feet, but
Why not?
Because you're in anaphylactic shock. I don't know what happened to you, so I don't want to put you in a position where stuffing it to your core. That's bad. But
Not why.
But it's right. I don't lift your feet up. I do the blanket. I
Why
do the
not?
air.
You have to know why.
Fuck. Oh, because you're swelling, right? And bringing too much blood up here would be bad. Are you kidding? I don't know. Man, I got farther than everyone else. You know what? Fuck it. I did good. I got you to the hospital at least.
Why do we not elevate the legs, sir?
That's a great fucking question.
Damn.
Oh crap! I literally answered this.
I don't hit my butt in your head.
When did the legs? Shut up. Don't lift. Don't lift. Is it something to do with kicks sympathetic response? The epical kicks sympathetic response with vasoconstriction. Is it seem like a fucking tachycardic? And
Why do we not elevate the legs?
Wait, I just said this. I said because you gave them a lot of epi, you don't want it on them.
Nope.
Because all the toxins have pooled.
Nope.
If you had anaphylactic shock, so maybe you fell and hit, like, injured yourself. So
No.
Can I guess?
Sure.
Is it because you were having trouble breathing?
No shit. Why would I have trouble breathing with anaphylaxis?
Oh.
Oh, I got it wrong.
No, you're right.
Oh,
But why would I
thank
have?
I was like,
Why would I have trouble
because
breathing with
your
anaphylaxis?
bronchioles constricted.
Right. So what lung sound would you hear? What is that?
Amazing.
Hey, I got you to the hospital at least.
Wheezing. Yeah, but again, you don't know why.
But I got you there, okay? You're alive because of me. I wouldn't be that disappointed. You're still here on this earth due to my brilliant expertise.
Because you put me in shock position.
Right.
Which means I'm laying what position?
Supine.
It's hard to
You
find
wheezing.
Mm-hmm. Do we have lay patients down who have respiratory distress?
No. But I got you to the hospital. You're saying
Doesn't matter.
no one else did.
You have to know why.
I'm your savior, Vince.
No.
I thought that was just for rings and fluid. Because then you're
Not
gonna
Doesn't
rapid
matter.
test, that's what I'm hearing.
Right. Again, we also talked about it, for rails, but again, do things inside the abdomen move.
Yeah.
If they're laying supine, is that going to put weight on the diaphragm?
yes.
Oh, yeah, it is.
Yeah. Okay, so diaphragm can't go down, decrease tidal volume. They already got small airways as it is, so it's going to increase the respiratory stress.
Okay.
Okay.
So the epi, because even though
It's not going to happen right away.
Right.
Right. So, as far as epi,
I think
okay.
we could have gotten it.
Yeah. See, if we didn't do it last time, like that teamwork,
We could talk to each other.
on point. We're like dream team right here.
I wouldn't say that. So,
Abbott Costello? Never.
Abbott Costello, yeah, no, Abbott
What's the
Costello,
guy's-
right.
What's the guy's name
Yeah.
for the other guys? The two like cops that died in the beginning? That'd be us. Right. Aim for the bushes.
The other guys. Yeah. So, anyways, as far as epi, okay, again, it's the easiest drug to give since the freaking instructions are on the actual medication itself.
Oh, I can't read it.
Clearly.
Well,
Okay.
you can't read it.
So, this one's kind of faded. But anyways,
I just can't read in general.
so, yeah, clearly. So, as far as administration of epi, okay, we want to go into the mid-lateral thigh. So we expose the area, take an alcohol prep pad, small circles to big circles, pop off the safety cap, holding it clear on both ends, pressing it till it clicks, hold down for how long?
10 seconds.
After that, where does this go?
Sharp.
Sharp container. Then we take a 4x4 to massage for 10 seconds. Right, let that medication work in, slap on a Band-Aid, and then transport code
3.
Reassessing every
5.
with
ALS.
right, as we go.
Oh, I forgot the ALS.
Yeah, see.
Hey.
So,
And position.
Valid's position, yeah. Okay. So,
You know, you're not being very nice. I'm gonna put you in a supine.
those, right, are going to be all of the medications that we can either assist with or assist in the administration of, right, for our patients. So, any questions? Yes, sir.
With endotracheal tube or advanced airway, what happens if the patient becomes conscious?
In that case, right, for our protocol, there's nothing we can do. ALS might be able to sedate and paralyze those patients like they would initially if they were to do intubation.
So once again, there's never a situation when it would actually be removed?
Not from us.
Once it's-
Yeah, not from us.
All right.
Yeah. All right. Any other questions?
And it feels better if you stab it and not like wait, click.
What's that?
It feels better when you just stab it versus like push it. That don't feel good.
I know.
Oh.
Yeah. I mean, it makes sense because it's just like hitting it hard, so it's that initial shock, you don't feel the needle.
Yeah.
What if the patient thinks they're having like an allergic reaction, but you don't see any signs of it, but they still give it to you?
Then you tell them, based on me running my assessment, I don't feel you have it because if you were, you would have this, this, or this.
What if?
What's your question?
No, that's stretching.
Oh, gotcha, no worries.
Oh, my question. Would we be liable to say, pull up? No, I don't have an EpiPen. We're sitting in the ambulance and they go, BAM! And hit themselves. You liable for that?
No, you're not liable for being an idiot.
Yes.
I cover all my bases in any scenario.
So,
I want to make sure.
as far as tomorrow, okay, for tomorrow, right, we're going to be covering our last new lecture, right, with any new information.
Oh my God.
Don't say
Okay.
that. You're making me sweat. Man.
What?
Yeah. Like I said last Friday, right, your class is shorter.
I think we should have an extra week to our whole schooling. I don't know if we're ready to be doing that type of stuff just yet.
Okay, so yeah, tomorrow's your last new lecture, right? Friday we're teaching your last few handful of new skills. And as I said, when you guys come back from dinner break on Friday, when you come back from dinner break on Friday, it's all review and testing from that point forward. Okay? So, yeah, now you guys are scared. Okay?
Yeah, I am.
And you should use this fear as your motivator. Okay? Because fear is a very great motivator. Okay? Not fear that you're not going to pass the class, because you can always go around. Okay? But based on the fact, yes, right, that it took 3/4 of the class to give the easiest drug we can assist with the administration of, okay, you should be fearful that you're not going to be able to do the thing that you need to do for your patient or hesitate and do the right thing at the wrong time, just like with resuscitation of a newborn. Okay? That should be your biggest motivator. Because again, you failed the class, big deal. Right? You pay the money, you go around another lap, big deal. Okay, but you guys should be confident in your abilities and your knowledge to be able to do your damn job. Okay, so now more than ever, you should take the next week, right, to get your crap down, because a week from tomorrow is going to be your written final exam. Yeah, and a week from Friday is your practical final exam, and then you'll be done for better or for worse.
There's no better for me.
So
You'll get 3s. Don't worry.
I'm
You got
hoping that
this.
when I get hired on, that the people there will realize I'm retarded and they'll be like, okay, well, here's some tips and tricks.
Hey, don't say that.
all right, so that's it. Go home.
Tweedledee and Tweedledum.
Wait, are we gonna get any information on the exams?
I don't know.
We're talking about
You gonna tell us how they're gonna be managed or run?
the skills exams.
Yeah, and
Next week.
Okay.
Can I take a quick picture? Yeah.